Hello, everybody. I would say we've had an incredible morning of speakers. I know I've learned a lot and just really appreciate everyone that we've had before. I'm really pleased to introduce our keynote speaker, who is an amazing clinician, educator, doctor in person, and we're so lucky to have him here with us today. Dr. Sheev Dattani is a leading colon and rectal surgeon and one of the most experienced robotic colorectal surgeons in the region. Dr. Dattani is board certified in both the United States and Canada and serves as chair of the robotics committee at Trinity Health. He's performed over 1,000 robotic colorectal procedures and was the first in Idaho to perform, I might say this wrong, a robotic TAMIS procedure. All right, thumbs up. Beyond his surgical expertise, Dr. Dattani is a recognized authority on diverticulitis, having published in the Journal of the American Academy of Family Physicians and presented at regional American College of Surgeons meetings. He also holds faculty positions at the University of Washington, Idaho College of Osteopathic Medicine, and Idaho State University, sharing his knowledge with the next generation of surgeons. Dr. Dattani, thank you for being here today.
Okay, so this is timed pretty good. I guess people are still eating their lunch, so sorry if you lose your appetite. I do have one surgical video. I had to put one in on a surgery talk, so hopefully you guys will be done eating by then. I'm booked for an hour, but as a typical surgeon, I will not go a full hour here, probably about 30 minutes. And if you guys have questions, you can ask me at the end. You can truly ask me anything. Let's see here. I have no disclosures. Boise's a lot bigger than this now. There's probably a lot of homes in those foothills, but really pretty picture of Boise. Okay, so I have to have a slide where I talk about myself. So I moved to Idaho in 2018. My wife was born and raised here. I do roughly about 6 colectomies a week. I think this week is kind of irregular. I'm doing more than that. As far as robotic surgery, as far as like learning how to do robotics and stuff in 2020, that's where I completed my first few hundred cases. And now I'm close to about 1,100 robotic surgeries. I do complex surgeries on Da Vinci, which I think for primary care doctors, it means basically a faster recovery, more precision with surgery, and less pain. I'm continuously learning. There's a surgeon group online where we share videos and we basically just roast each other about different cases and different things, but you can also get opinions from across the country. So if I have a really complex case, I'll usually put the case up and then I'll get opinions from, Mayo Clinic, Mount Sinai, California, various hospitals. So it's been really great. I'm really critical of my own outcomes. I collect my own data. And I really focus on different technical aspects of my operation. I started teaching surgeons. So you guys may not know this, but I'm a case observation site for robotic surgery. So I have surgeons that will watch surgeries, and I sometimes will go to various places to teach robotic surgery to surgeons that are operating. And most recently, I have a lab at various places in the United States where I teach surgery to surgeons on cadavers. This is my team. So you may recognize some of these people. Anthony's my partner. I trained in Tampa, and then when I left, he came and interviewed. And so we were trained by the same person in Tampa, and then Anthony went and did another fellowship after. We had Jenny join Anthony as his PA. My PA at that time, she went to med school and she had left, and Kelsey joined us. She's one of Jenny's friends. And Melissa, she's in the back, bright red with the scrub cap on. She was my student from ISU, PA student. So that is our team. And we're looking for a third colorectal surgeon. We have an ad posted as of, I think, 2 days ago. If anybody knows anyone, like Matt Nelson, whose brother is colorectal surgeon. Okay. All right, so this is what we're going to talk about. We're going to review the general management of diverticulitis, antibiotics and uncomplicated, when to get a colonoscopy, when patients should have a sigmoidectomy. And there's other different pathologies like SCAD, which we'll talk about. And at the end, you guys can ask me any questions. Just so I know who's in the audience, how many primary care providers do we have? If you don't mind putting your hand up. Okay. I didn't see who didn't put their hand up, I guess, but any other specialties out here? Internal medicine? Okay. Any surgeons? All right. We got one cardiologist there. Cool. All right. So the basics. So diverticulitis, or small pouches in the colon. They're most commonly in the sigmoid or left colon, and that's generally in Western populations. In Asian populations, we see them mostly proximally in the right colon. So diverticulitis is when one of these diverticuli get impacted or obstructed with a fecalith, leading to microperforation, inflammation, and bacteria can overgrow in the area. There are some risk factors. There are things we can do to reduce the chance of getting diverticuli, but there are things that we can't change, some of which is genetics. We see, and this is relatively new, where some families have, many family members that have diverticuli, but also we see them with the low fiber diet, obesity, physical inactivity, smokers have an increased risk, and high red meat intake. Some medications like NSAIDs, steroids, and other immunosuppressive drugs can lead to diverticuli. What else? So protective measures are kind of like everything you tell your patients to be healthy, like don't smoke, don't start smoking, try to avoid alcohol, exercise, eat like a healthy, nutritious diet. So, I mean, that, and also for cancer, all those same things carry over for cancer and pretty much every other disease. I'm sure, I don't want to keep picking on Matt Nelson, but as a cardiologist, he probably tells his patients the same thing. So the basics, so the classic symptoms are left lower quadrant pain. That's generally where the sigmoid colon lives. Change in bowel habits, constipation, or diarrhea are classics, can be part of the classic symptoms of an acute flare. There can be urinary symptoms, especially in men. Have your spidey senses up. Sometimes we find fistulas where the colon is connected to the bladder. So if you have a male patient with recurrent urinary tract infections, it's not, to order a CAT scan may be reasonable. The differential diagnosis is IBS, constipation, appendicitis, inflammatory bowel disease, cancer, some gynecologic conditions, UTI, ischemic colitis. The red flags for a complicated episode, like for the primary care docs here in your office, if they have a fever, I'd probably just send them to the ER. I mean, you want to make sure they don't have an abscess or something really bad going on, or a perforation. They have severe pain that's unrelenting, send them. Signs of peritonitis, so rebound, guarding. If they're not really taking down fluids very well, or they're not able to eat, they could get very dehydrated. Or they're on immunosuppression, or they're a patient that's kind of, that frail patient you have that you see and you're like, oh, they're probably going to be okay. Probably send those patients to the ER as well. So this topic, I should have said this at the beginning, but why this topic is really important is, there are some controversial things, but it's one of the leading causes why patients actually go to the ER. The third most common inpatient diagnosis, and we've seen about a 55% increase in emergency admissions in the last decade. There's still so much we don't know. I personally think it's a fascinating topic, but that's more reasons why I think this talk is important. So the diagnostic approach, labs, imaging, patients who fail to improve, CT scan is important. So if you have that patient that's had another recurrent flare and they're in your office and you're wondering what to do, let me hit play again. Okay, I think I'm at the beginning of all the slides. Okay, let me just see where to start. Keep going up or down? You guys have already seen this stuff. Keep going, Dattani. Okay, let's see. Okay, are you controlling over there? Okay, I thought I was going crazy. I'm like, oh, what is going on? I guess while it's loading, do you guys have any questions right now? Because we have this pause in the back over there. No, so age is not a complication. Okay, so the question is age complication for diverticulitis? And no. Okay. Oh, I see. Okay, so yeah, I think so. I guess I don't know the answer to that one. So I think so. The way I was interpreting that question is, and the way I think about it as a surgeon is uncomplicated versus complicated episodes of diverticulitis, and that I'll get into. But I think for you is the question you asked is when should I send a patient to the ER? Is age 65 plus something I should be concerned about? And I would say, yeah, I would agree. And I'm not aware of those guidelines. The guidelines I've been following are the American Society of Colorectal Surgeons, and mostly they're geared towards surgery. Oh, yeah, I can flip them over here. Okay, I'll take one more question. I'll keep going. Okay. So it usually involves mucosal disruption, okay, when you have an acute flare. Bacteria can translocate like many GI pathologies where it lead to infection and a regional area can get inflamed. There's another theory where there's a vasa recti, they're little tiny blood vessels, and that's a natural area where diverticuli can pouch out from. Diverticuli are really common in those age kind of 55 and older. The preventative stuff we've been over. There are things that people can do in their diet to reduce formation of diverticuli. Some people, they are just going to have a kind of, the genetics where they're set up to have them. And I'll take more questions at the end if you guys are okay with that. So the classification, the way we break this down is to uncomplicated and complicated. It goes into two buckets. With uncomplicated, it's further broken down to the Hinchey classification. So that would be a Hinchey 1A. And that's where the sigmoid colon is regionally inflamed. There's no abscess. There may be a phlegmon. There's no fluid collection. This goes all the way down to Hinchey 4, which is feculent peritonitis, where there's a perforation and there's stool contaminating the abdomen. So I want to talk about it shouldn't be controversial anymore, but the uncomplicated diverticulitis and the role of antibiotics. So there is data that supports emission of antibiotics. I'll show you guys some data. There's no difference in readmission, change in treatment strategy, emergency surgery, worsening or persistent diverticulitis symptoms. This is from a meta-analysis in 2023. So this is 4 RCTs with over 1,800 patients. The population is patients with acute uncomplicated diverticulitis. So these are the patients that you may be seeing in your clinic. They're not the ones that are like febrile and septic looking. They're not the ones with an abscess. These are the Hinchey 1. So if you guys remember that diagram I showed you, the sigmoid colon's inflamed, and the intervention is antibiotics or not. And the outcomes are emergency surgery, time to recovery, length of stay, and hospital admission. And you can see the readmission, change in strategy. You can see the odds ratio there. There's no difference. So we can say that there's level 1 data supporting omission of antibiotics. It can be safe and effective. And I guess the question is, why do we still use antibiotics? And I think it's really important, to focus on, these are patients, the ones you're seeing in your clinic, and they're like, have that left lower quadrant pain. They've had a scan in the past. They've had their scope. Like, it's like the safe one. You can safely omit antibiotics, and there has been data out for over a decade. I mean, even since I was a resident, this is one of our journal club talks. There's data that came from Europe. And so there's this change in paradigm. Some reasons why we still give antibiotics. I mean, I think we're scared of a bad outcome. You have that one patient and you're like, well, what if like it's different for them? And then they're going to be really mad or they're going to be all up on my chart and send me all these messages. Can you ask at the end? Is that okay? It's a change in paradigm. You got to feel comfortable about it. And again, it's kind of like the patient is having a flare. It seems mild. They've had it before. I think it's worth considering avoiding antibiotics in these patients. So like, what do? I think patients with systemic symptoms, tachycardia or fever, I'm going to treat those patients with antibiotics. All right. So I don't know if any of you guys are good at reading CT, but this is one slice of a CT scan. For those that have paid attention to the earlier slides, does anyone want to pipe in and say what they think the differential may be on this CAT scan? And if no one is feeling kind of, interested, I got 2 med students back there. I can bug them. Like, yeah, there, it looks like there's maybe a microperforation. There's some regional stranding. So this could be diverticulitis, right? And I'll ask my med students in the back, what else could this CAT scan be? Like, what would be the differential for this? IBD, okay. I think I heard someone say cancer. Yeah, I think that's a really good one to bring up. And here, so this is the colon. It looks like there's like a little bit of air, extraluminal air there and there. The other one is ischemic colitis. So I guess my question is, when you see inflammation of the sigmoid colon and there's fluid or air around it, you don't want to think it could just be diverticulitis. You want to think, what's the worst case thing? Could it be colon cancer? It could also be IBD, just to have the differential in your mind that it may not always be that. And that takes me to my next slide. I mean, with complicated diverticulitis, actually 11% of these patients may have colon cancer. I see it about a few times a year in my clinic. I don't let people, I have a rule where I don't like operating unless patients had a scope. And, we obviously don't scope these people right away, but we know there's a malignancy risk associated with this, not with diverticulitis itself, but it's a mimicker of cancer. With uncomplicated diverticulitis, it's about a 0.7% risk, and that's the same as the general population. I thought this was a really cool slide. So, unfortunately, we're doing better for screening, but it's just another kind of a pump up to try to tell your patients to get their screening done. I mean, I personally, colonoscopy is the gold standard, but any screening I think is good. The Cologuard test, the FIT testing. I mean, if they don't have symptoms, if they don't have a first, a relative or personal history of colonic polyps, I mean, for that average risk patient, I'm willing to accept any screening, especially in Idaho. I mean, we were third worst in the country for many years. Now I think we're 40th out of all the states. So we're like the bottom third, which is a big move up for us, which I think is good. So just another pump here for encouraging your patients to get their colonoscopy done. All right, so when do we scope these patients after a complicated episode? The other thing we're short of in Idaho is doctors. I think we're short like 1,200. So even if you send them for a scope, they're probably not going to get it done for a little while, and that's actually okay. So timing, these are expert opinion. Our colorectal guidelines were a little bit more bold. At 6 weeks, we offer colonoscopy, and the AGA guidelines or the gastroenterology guidelines suggest that 6 to 8 weeks after a complicated episode. For me to do surgery on the patient, unless they have a stricture or perforation, or like, I'm not going to scope them if they're acutely presenting in the hospital and need surgery, but if they're outpatient, they should get their scope done. So if you're putting a referral in, it's always nice to put one in for us and then one in for GI to complete a colonoscopy. This slide's for Mary Baranaga. This is a really awesome slide, and the reason I bring up her name, this is a study from UW. It disproved the theory of nuts, corn, popcorn consumption and the incidence of diverticular disease. So historically, patients have been advised to avoid consuming seeds, corn, nuts, out of the concern that undigested fragments of such foods could become lodged within a diverticulum and incite a flare. However, this theory was disproven in a large prospective study with over 47,000 patients. However, like if you have that one patient and they're like, I eat watermelon and then I have a flare, I mean, probably they shouldn't eat watermelon then. But like I wouldn't suggest arguing with them. But like some of the older patients, I'm like, okay, like, just don't eat that. But I know it's probably okay. Kudos to UW there. Okay, when do I offer surgery? So it's individualized based on risk factors, multiple episodes of uncomplicated, single episode of complicated, fistula or stricture. So the 3 and then your colon comes out thing is kind of like an old thing. We know that recurrent uncomplicated diverticulitis, the first episode is generally the worst. Generally, they don't go on to have like a perforation or abscess or something bad happen. I try to, when I see these patients mostly, and I do enjoy getting them referred, I try to make sure their colonoscopy is up to date. The other thing is I try to look at all their CAT scans and try to get an idea of their symptoms and timing. And we have like weird charts in our office, like the Bristol scale, to try to see if they're like where they are on Bristol, working through constipation. And back to that like second or third slide, like all the things that all of us should be doing, like trying to live a healthy lifestyle. So I try to make sure they've done all that. And usually I don't have to operate on all these patients. I mean, it's still the #1 indication for colorectal surgery or colon surgery in the country, but I truly think that not all people need surgery. But there are some people that really do. And, these are not my personal thoughts. These are from our ASCRS guidelines. Patients with multiple episodes of uncomplicated where it's impacting their quality of life. Single episode of complicated, if they've had an abscess, they're probably going to recur. fistula or stricture. So if they have, when the colon gets inflamed, it gets sticky and it can adhere to other organs like the vagina in those women that have had a hysterectomy, the bladder in men. The colon can stick to the rectum, the small bowel. So if patients have a fistula, it's not going to go away by itself. So stricture is where the colon's been inflamed so many times that it becomes almost like a lead pipe. And so that's not going to get better. It's not going to go away. Those patients generally are going to need surgery. I did it again. Okay. I just pressed the forward button too. Hopefully I'm not the only speaker. Okay. From current slide. Let's see. Yes. Okay. All right. So interval sigmoidectomy. When do I offer this? So the data supports offering surgery to appropriate MIS candidates who have recurrent, complicated, or persistently symptomatic diverticulitis. And they looked at these GI quality of life scores at 6 months. And this study was interesting because they looked at the complication rate and the rate for temporary stoma. So they had a randomized control trial, multi-center, 128 patients, 90 were randomized. And the population was recurrent, complicated, or persistent symptomatic diverticulitis. They excluded patients that didn't have a colonoscopy. They had a contraindication to MIS surgery. So MIS is minimally invasive, robotic, or laparoscopic surgery. The intervention was a sigmoidectomy versus conservative management. And they looked at outcomes. They specifically looked at the GI quality of life score at 6 months. There were some limitations in the study, which is small sample size, some missing response data. Maybe people were doing a little bit too well that they didn't want to respond. But overall, I use this as a framework for these people with uncomplicated recurrent diverticulitis to tease out, like, I don't want to dismiss their symptoms and say, oh yeah, like uncomplicated, like go on your way, don't need a surgery and just get your scope done. But I really take these, how they're feeling seriously, and I try to tease out, well, how much is it bothering you? What have you tried? All patients in this study had some form of active management, received antibiotics, perc drainage, even lap lavage, which is like a laparoscopic washout of an abscess. It's important to note most had symptoms at least weekly, and in my opinion, that's a significant indicator of quality of life. Again, the important thing is they reveal the surgical complications, which is helpful when I, discuss the risk with patients in the office. I bring up that there's been studies that show for elective surgery for diverticulitis, 5% risk for temporary stoma, and the surgical complication rate's about 10%. I collect my own data. For my surgeries, it's different. I mean, I've done about 1,200 colectomies, but it's a good framework when you're discussing with patients. So interval sigmoidectomy appropriate MIS candidates who have improved pain and quality of life score at 6 months with low risk of complications. This is what I'm going to offer. We talked about the stoma and the complication rate. So this is like kind of in the middle of the presentation. So it is safe to omit antibiotics in select patients with uncomplicated episodes. There's a malignancy risk with complicated. It can mask cancer. Interval MIS sigmoidectomy improves quality of life with low risk in patients with recurrent, with complicated or smoldering diverticulitis. All right, so like what's going on in 2026? Like how are we doing our surgeries now? It's trending more towards outpatient. I had a friend from Houston and she has published a lot of articles on outpatient colon surgery. She came and gave a talk in Boise. And it is trending more towards, shorter length of stay. The complication rate I find is, very low after colectomy. We do a lot of education preoperatively and postoperatively. So the patients that you guys send to me that I end up operating on, I really try to include the family. If I'm offering surgery to someone, a major abdominal surgery, they need to have another person there, another set of ears, so everyone's hearing kind of the same thing. In preoperative optimization, I mean, these patients, sometimes they've had a flare and they're like, I can't eat. I mean, they could try to get a protein shake in, even a clear liquid Ensure. They should work on their comorbidities. I mean, maybe this is a wake up for them if they've like an uncomplicated flare. Maybe this is, they should quit smoking or quit, drinking so much, or, listen to their PCP and maybe work on their hemoglobin A1C. The other thing I do, so when I do surgery on patients, is we do multimodal pain management. We have some of our pain management providers there. There are things we do to try not to consult you guys. And one of them is I do what's called a tap block, where I inject local anesthetic and low dose steroids into the abdominal wall to freeze the nerves my incisions kind of go across the abdomen, so to freeze the incision sites, especially the extraction site, to help reduce postoperative pain. We load the patients with some medications preoperatively to block the pain receptors before we give pain, before the patient has pain. We have some newer medications. We have a medication called Entereg, and it's a mu opioid receptor blocker at the level of the bowel, which we give preoperatively to help prevent ileus. I had to put one so I'm almost done. This is just like another differential for diverticulitis. I had to put some more medical stuff in here because I usually present to surgeons, but we'll talk briefly about SCAD, SCAD versus diverticulitis versus IBD, the endoscopic diagnosis and management. So what this is it's segmental colitis associated with diverticulosis or diverticular colitis, and is characterized by chronic inflammation in a segment of colon with diverticuli. It's uncommon, so it shouldn't be like, oh, this patient has SCAD. I mean, I've seen maybe 1 or 2 patients with this. And the pathogenesis of SCAD has yet to be defined. The GI nerds are, thinking it could be mucosal prolapse, fecal stasis, localized ischemia. These are all things that could have been implicated. This is what it looks like endoscopically. So you can see the arrows. The white ones are going to a diverticular opening, but the inflammation is kind of in a different area. It's around it, but not around the diverticuli. And there's clear sparing of the diverticular orifices. Prevalence is pretty low. I mean, this shouldn't be your #1 differential. I mean, for me, I'm always thinking, could it be cancer? But it's about, less than 4% of patients undergoing colonoscopy, they'll find this. And this is, about a 1.5 to 11% of patients with diverticulosis. The incidence is still quite low. We talked about the unclear pathogenesis. Traditionally, it was considered part of the diverticular disease spectrum, but now, these gastroenterologists are thinking that it's probably something to do closer to the IBD spectrum. Similarities are older ages are affects similar segments of bowel. It's limited to areas of diverticuli, like not around the diverticular orifices, but that area of the colon. And there's sparing of non-diverticular bowel. The differences are endoscopic findings are characteristic versus nonspecific in diverticular disease. There's no leukocytosis. There's no pericolonic inflammation on CT, and TNF alpha is often overexpressed. The similarities, versus IBD is it may affect in similar segments. TNF alpha is overexpressed. Endoscopic lesions appear similar, histologically similar, and it responds to misalamine, which is treatment for IBD. The difference is it affects older patients, where IBD generally there's like a split curve there, and it's limited to diverticular segments. There's lower complications in SCAD and lower relapse in SCAD as well. So the treatment is largely based in a case series and clinical experience treating diverticular disease and IBD. It's described to be self-limited. It resolves with medical management. I generally don't offer surgery to these patients, but in some cases I see how it could be offered. And there's many different algorithms which we will not go into today for the sake of time. So summary, it's an unusual diagnosis. There's intradiverticular inflammation limited to the sigmoid. The rectum is spared. It can be closely related to IBD. There's 4 different subtypes, which we will not go into today. Surgery is rarely indicated and management similar to IBD. Oh, I had to put a surgery video in. That was my last slide. So if you guys have any questions while the video is playing, you guys can ask. Just briefly, this is sigmoidectomy. So this is a robotic surgery. So it's sped up. I think this is like double speed. The video is only a few minutes. These instruments, like these scissors, they may look huge, but they're about like 6 or 7 millimeters. Same with the other instruments. This, like the tissue I'm taking off of here is the colon. So this is a diverticular segment that's inflamed, and I'm taking it off the bladder. I think this is a cool case. Some people may think it's weird, but I do natural orifice extraction where I remove the sigmoid colon, and if they've had a hysterectomy, I'll remove the colon through the vagina. So there's 4 incisions, and I know it sounds weird, but patients have less pain, less hernia, and the next day they're like, why am I even in the hospital? They end up just going home. So this is kind of what's trending in colorectal surgery is like I'm able to do the whole operation through 4 incisions. And at the end of the surgery, I'm like, well, where do I take it out from? Because I can make a really small incision to take this area of colon out from, from the body. Some surgeons, they do a transrectal extraction. which I find like I personally don't like doing that. I have done it a few times. What else? This is, there's 21 steps to the operation. So we usually ligate a major blood vessel when we're doing the operation. This is the IMA. You guys may remember from med school, there's collateral blood flow. And this is usually one of the first steps, I do during the operation. Let's say I have a fistula, I take that down. That green line you guys saw, that's the ureter. So if I've operated on any of your patients, I do a cystoscopy and I put dye in the ureters. I don't know if any of you guys have done like an intern year or done any, like I'm sure you did some surgery rotations and maybe were involved in a colon resection, but for bowel surgeons, we're usually really worried about a few things. One is the connection, the bowel connection when we're done. And two is the ureter. It's a drain tube. Obviously that goes from the kidney to the bladder, and usually it's camouflage where we're operating. So I usually put dye inside the ureter. So I do a cystoscopy, which adds about 30 seconds to the operation. And I put dye in each ureter, and I take the stent and I throw it away. So there's no permanent stent in. I have a 0 ureter injury rate, and in our literature, it's about 1%. So I guess I should have had about 12 by now. And as you guys know, it's, for the patient, like they never really go back to normal after a ureter injury. It's always something like a stricture, or they're having a lot of appointments with the urologist, and it's not great. So this helps protect the patient and protect me and keeps me in the right planes. This is a vaginotomy where I made an incision where the patient had a hysterectomy previously, and then we're taking the colon out through the vagina. I know it's kind of yuck, but the patient's happy. I mean, if you think about it, you think about the wound infections, the staples, the disgusting wounds you guys see in clinic. I mean, they got wound vacs and stuff. I mean, this is, I think, great. And I think in 2026, I know it's a weird concept, but I think it's the future of surgery, is natural orifice surgery. Incisions are only going to get smaller. Patients, I think, with robotic surgery, everything's a lot more precise. The length of stay has changed. I think expectations have changed for surgery too. I mean, I have patients, they're asking, if we're doing robotic or minimally invasive surgery. So this is closing the vaginotomy. That other device, you can see that little piece of metal, that tube hanging out. We staple the bowel together. Sometimes I suture it together. Sometimes I staple it. Stapling is the most common way. Like if you go to a different city, a different state, a different country, they're going to say, oh yeah, we use that same thing. It's not unique to Boise. It's called the EEA stapler. And what it does is it makes a circular stapled anastomosis. It cuts between, and then we remove it. What else? Everyone looks really scared now. Any other questions, guys? Over there.
Does the skill with the Da Vinci correlate with how many video games they played?
Yeah, there actually has been a study. I didn't read it. I actually didn't. I wasn't really into video games. There actually has been a study in JAMA. I think it was like a year or two ago, and there was a correlation between video games and minimally invasive surgery, showing that all the things like better technique, etc. So yeah, over there, in the front row. Go ahead, sir.
Choice of antibiotics for diverticulitis, still a quinolone and metronidazole, or is there?
I usually try to avoid antibiotics, but when I'm giving antibiotics, I usually ask what they've taken in the past that's worked, because I have patients that are like, oh, I've tried Augmentin, and that one doctor gave it to me and it never worked, and I saw someone else and they put me on the right stuff. I think you're basically, it's usually ciproflagyl or Augmentin. And again, trying to focus on alleviating constipation, increasing fluid intake, and there are theories that it's inflammatory instead of infectious. So it's usually my choice of antibiotics. Go ahead in the back.
Yeah, two questions. First question is, so fecalith is similar pathology like for appendicitis blockage?
Yeah, exactly.
Okay, and the other question is, my understanding is robotic surgery is way easier to learn than laparoscopic. Is that really true? And are there any limits to what the robotic surgery can do? What's its role?
So robotic surgery, I think, is really beneficial for complex operations. I feel like the robot was made for colorectal surgery. Good thing there's no other surgeons here. We use everything for it. So the wrists are, they go 270 degrees. So I can get into all different parts of the abdomen that you can't manage laparoscopically with robotic surgery. The instruments can bend and twist in different ways that laparoscopic can. It's like straight stick with laparoscopic. It's pure punishment to the surgeon. I mean, like I had partners that have retired, both had shoulder surgery. I mean, they just blew their shoulders out doing surgery, and they were physically tired after surgery, where we're sitting. I mean, if I have surgery on me, I want the surgeon to be comfortable. I don't want them to be like, oh, when is this going to be over? And then their shoulders are hurting, and it just doesn't sound good. Also, for laparoscopic surgery, they have an assistant, and the assistant has to read their mind on where to look. And imagine if that assistant's gone, then they're like yelling at the other person, like, look left, look right. And it's a lot. With robotic surgery, I move my head and the camera moves. It's 4K, it's 3D. I have two left hands and a right hand. I have assistants, they're great, but it gives me more control. I can, there are really small details of surgery that I actually think are really important. One, I really try to avoid, like, as far as post-operative pain, anything I can do to reduce it. And there's a theory on, well, there's two theories. One is, it's called the no-touch technique. So instead of me grabbing the bowel, I try to push things instead of grab. The other thing is what was I gonna say? Reducing pain. I mean, the incision size. Dang, I forgot. Oh shoot,
There's data that shows that the empathy of your provider reduces post-operative pain. So
okay.
you got that going for you.
All right. Dang, I forgot I was gonna go with that, but okay, go ahead in the back.
Yeah, I've had a patient now who's had 2 or 3 episodes of diverticulitis. She always goes into the emergency room. They confirm it with a CAT scan.
Yeah.
But I have not been able to convince her to do either a colonoscopy, which I have tried multiple times, or, I've done other things to try.
Yeah.
But that's for bowels and stuff like that. But this last episode was much longer. And I then started talking about stricture.
Yeah.
And so I'm hoping she'll get the colonoscopy done this time, because I'm really thinking she's at that point where she may need surgery.
Yeah, I think documenting in the chart's very important. I do that a lot. I find that some patients don't want to follow a typical path, and I see that a lot with cancer patients. And I don't want to drop them as a patient, but I have like the 2026 cancer guidelines, and I'm following them to a T. And they're like, well, I don't want to do that. I want to take this one medication from this one like non-traditional like health center in this town. I'm like, okay, but I still want to do their scopes, and just same with diverticulitis. I mean, I have patients that have had an abscess, and I know they're going to recur, and I'm like, my in-laws have a place in McCall. I'm there on the weekends sometimes, and if you call me and you have a perforation, like I may not be available. You'll just get whoever's on call. And which is fine. There's a lot of good doctors, but I think setting expectations that, okay, there's a 11% malignancy risk and it's a mimicker of diverticulitis, and our screening is like one of the lowest in the country. You should really consider getting a colonoscopy. And if you meet with a surgeon, they're not just trying to operate on you, but they can teach you or tell you how to avoid surgery and how to get better. I mean, I really try to focus on that in my office. Still really bothered me. I wasn't sure where I was going with that last question. I don't know how I forgot.
Hi, question on diverticulitis and not using antibiotics versus using
Yes.
symptomatic pain relief more quickly, or there is just zero, like nothing, no benefit?
So I think with uncomplicated diverticulitis, it's a whole different theory, right? It's more of an inflammatory thing. So symptomatic pain relief, I can send you that study so you can read it. But as far as pain relief and return to kind of usual function, it's going to be the same, or it's going to be there's going to be no change. And that data has been out for a long time. I remember having a journal club. I think I was like a second-year resident, and it was very controversial then, but now only more data has emerged. Anything else, guys? All right. Thanks everyone for having me speak, and there's no other questions. You guys feel free to email me or call me or text me anytime if you need anything.
Our next speaker is remote. So we'll, I believe, start in about 15 minutes, just to keep things going on time. If you want to stand up and stretch, it's good for your bodies. I'm a former exercise physiologist.
They said she was gonna.
Can you hear us, Callie?
She came in the first day and walked all the way down the hall without help.
That's good.
Yeah. So we just met her for 2 days and they were like, she doesn't even need a walker or a cane, nothing.
Callie, can you hear us?
It's fine. It's crazy. Yeah.
I think.
A lot of work.
Oh my God, I spent like 2 hours yesterday trying to get her situated. When I got there, her blood sugar was 40.
How's that possible? It was 200 the whole time no one was me.
don't know.
That's the reason I took away the sliding scale when I discharged her, because I was like, I don't trust him to do a sliding scale. So I removed it and put like 5 units with meals. It's like,
Our mic is muted. It's not here for helping this.
okay, good. So yeah, I removed that, made it
Carla, can you hear us?
5 units, and I put instructions. If they don't eat,
Wow.
don't give.
Make this bigger so
She
the
was
room
40.
can see.
probably not gonna
Oh,
work
she's
out.
sharing.
Oh, okay.
I think she was supposed to originally go home. It's like Eugene with her mom, her daughters. What's
She,
the
she went to memory lane,
interesting?
which interesting because she's not. And she like doesn't want to come out of her room because it's too depressing to sit at
That's
the
all.
table with people that are.
Oh, that's really sad.
Like, yeah, it's kind of not a good fit for her.
That's gonna make her forgetful.
No.
Yeah, I think. No, I'm assuming. So.
Well, we may not be.
Maybe should I just do that? The maximize the tool?
Well,
No.
she's gonna have to.
So she'll.
Yeah.
Yeah.
She does.
Do you want me to send a note on Teams? I can.
But we can see it all here.
Oh, I'm messaging them. They just haven't looked at their phone yet.
Okay.
Supposed to. See?
It is muted.
Ashley and Boise can hear us, so.
So she's still
Good.
Yeah.
So nice outside. And my watch said it's only 43.
It's beautiful outside. It's cold, but it's beautiful. I'm still.
So warm recently.
I know.
But the mountain's not open because there's a lot of snow up there again.
That's what I heard.
Yeah.
Got a snowmobile and can ride up to the top, you can still ski down.
Sure, I
Oh
was
my
thinking
God,
about
people snap.
snowshoeing up.
Sharing this out.
Yeah. They're having issues hearing us, but other people can
Oh.
hear us.
Ashley, is that you?
It's me.
Okay, we hear you.
Perfect. We hear you too. Technology, it works sometimes.
Dr. Lisa Nelson will introduce Dr. Lanning in just a few minutes.
That confused me for a second.
Thought she was gonna call you.
Buddy, she'll talk about the two Lisas probably.
You know how to make it bigger so the rest of, so we can. Me too. I will be able to see.
You making it with gluten-free is less calories too. And when my father was up, I made everything.
Takes away some of the flavor, but it's not a big deal. It's easier in a lot of ways too.
You're just gonna go through your slides like we. So. He was gonna try to get that ultrasound on the scoliar. Okay.
Okay.
That would be July, right? Very. That would be super helpful. I like literally needed it every day. But then when I get it, I think these parts, but.
Yeah.
A lot. Like, what if I got? What if I got? What did you do to yourself? I know. Thankful. Thanks. Love that we made it a little bit of a challenge for them. Yeah, it keeps everyone on their toes, which is healthy. Did you hear?
All right, everybody, we are circling back. It's time to get going with our next talk. And our presenter is coming to us from Baker City, Oregon. Dr. Lisa Lanning is an osteopathic family physician, which means she comes from a long line of healers who believe that the body, mind, and spirit are interconnected and interdependent. She believes that one cannot have wellness in the body when one is sick in spirit. To Dr. Lanning, holistic wellness means that physician and person partner together to address the entirety of what is causing physical and emotional symptoms, and together formulate a treatment plan that incorporates integrative principles. Dr. Lanning is certified in lifestyle medicine and helps patients focus on better sleep, nutrition, relationships, physical exercise, social connectedness, and avoidance of risky substances. She is skilled in osteopathic manipulation of the spine and extremities, treating both acute and chronic pain from arthritis, muscle strains and sprains, headaches, and fibromyalgia. Dr. Lanning, thanks so much for joining us today, and we are really looking forward to your talk.
Well, thank you, Dr. Nelson. I first want to make sure that y'all can hear me, and can you see me? If someone raise a hand or.
Yes, we can hear you, and I'm standing to the side of the screen. Thumbs up if we can see her. Thumbs are up. Okay, we're good.
Okay, awesome, excellent. Cool, thanks so much. So some of you may know I moved here to rural Baker County, Oregon, about not quite 3 years ago from what I thought was rural Florence, South Carolina. I trained in a rural family medicine program. Rural in name only. It was still a level 2 trauma center. We still had 130 bed ICU, NICU. I could go down the hall and knock on the interventional radiologist's door and reach the neurointerventionalist and ask a PICU physician for help. And now I'm here at Baker, where we are 2 hours away from all of you esteemed colleagues, and we're thankful that you're there. I'm coming on the heels of people who have spoken before me. I really appreciated Dr. Suleman's talk on interpersonal violence. Have seen way more of that here than I kind of expected to. I did grow up in Western Oregon and I spent about 20 years in South Carolina. So there's a little south there if you get me fired up enough. I want to talk to you about really my experience in coming to Baker County from another part of the world, honestly, and just the crash course in population health that I got here. We practice family medicine in our rural health center, rural health clinic in Baker City. And this is our lived experience. You know, this is population health is what we do. Community medicine is family medicine. That is what we do in Baker every single day. Baker County is vast, it's rugged, it's beautiful. It is also one of the most sparsely populated places in the state. Our patients are older, lots of them are veterans, many live on fixed incomes. Health is shaped less by diagnosis and much more by distance in Baker, where we are. So in rural communities like ours, access is the intervention. When primary care, specialty care, behavioral health, or transportation are hours away, disease progresses silently. Diabetes worsens, vascular disease advances, cancers are found later, and mental health crises escalate, suicides are completed. Over the next few minutes, I'm going to share data from Baker County, but more importantly, I'm going to share stories. These are stories of our patients who drive hundreds of miles for care. These are families who lose work days, people who lose their vision, limbs, sometimes hope, not because treatments don't work or don't exist, but because that care is too far away. So we're not talking about rural hardship just for its own sake. I want you to know we appreciate what you do, but I want you to also see this as an opportunity. If we can bring more care here into the rural facilities where we are and where our people are, where people live, we can prevent crises, reduce transfers, lower costs, and preserve dignity. So my bottom line, rural medicine is not a compromise. When it's done well, it's smart population health, which is important to all of us. And Baker County shows us by closing that distance isn't just compassionate, saves lives. So lots of thanks to Business Intelligence, the people who helped me get some information, to our Administrator and Vice President of Eastern Oregon, Tony Swart, and Shelley Cutler, who helped me get some more information. And I have no disclosures, except I did shamelessly lift some photos from Oregon Department of Transportation. So what happens when you are in rural Baker County and maybe you need to get somebody out by ambulance or helicopter, maybe you can't fly, maybe it's a STEMI, maybe it's a time-sensitive major stroke, a trauma, happens often, we're right on the I-84 corridor. But what if there's a semi carrying a large wind turbine and it fails to negotiate a curve on I-84 somewhere between Baker and Ontario, crashes over the median and blocks I-84 in both directions for 30 hours. That happened to us 2 years ago. You couldn't get in or out. There was absolutely nothing going for about a 100-mile stretch between Pendleton, I think, and Ontario. And it took a very special crane brought in from, it was at least Portland, I may have been Seattle, to get that very heavy turbine off and repair and get the freeway open again. And, you know, that is an extreme situation, but we actually experience situations where our freeways close often because of another truck accident, overturning weather. In the winter, it's not unusual for stretches of I-84, which is really the only easy way in and out between Baker and Boise, to close for several hours, several times a week. So when I first came to Baker, even before I interviewed, I wanted to know what are the community health needs. So I looked at the community health needs assessment. I think that was at the time in 21. The most recent is 2023. And, you know, in red, you can see is our Baker County, far northeast Oregon, pretty close to Idaho, pretty close to southeast Washington. And it is you know, relatively large, geographically speaking, county, not nearly as large as some of the counties below it that are even, you know, more sparsely populated. But this is, you know, really helpful. The largest cities in Baker County are Baker City, Sumter, and Huntington, which you'll pass on I-84 as you're crossing through. So large county, about 3,000 square miles, about 30% forested, it's rugged terrain, so a lot of that is uninhabitable. About 16,000 people, depending on the census, about 10,000 of those people in Baker City itself, here in the center of the county. And it's, pretty sparsely populated, about 3 people per square mile. A little factoid I like, about 4 cattle per 1 person. We are cattle country. And it is truly the end of the Oregon Trail. It was the last of the gold rush. There's a lot of mining and agriculture, ranching and tourism that happens in Baker County. So you can see Baker City centrally, I-84 comes from La Grande to the west and to Vail and into Boise to the east. And then we have many smaller communities halfway in the far northeast corner, where we have lots of people that we serve: Sparta, Pleasant Valley, Durkee, Hereford, Unity. These are all places within our area, Haines and Sumter, and none of them are a straight shot into Baker. Even though that stretch from Baker to halfway looks like it would be a relatively quick drive on 86, this rural 86 is about 37 miles as the crow flies. It's about an hour and a half to get from that place into Baker, where our medical services are. It's a beautiful place, lots of open skies, lots of ranching. One of our medical assistants, Veronica, shared these beautiful pictures with me, and I really appreciate that she shared them so much. So how rural is rural in Eastern Oregon? We're pretty darn rural. So remember, we're way out here on the far northeast corner, this little kind of Oregon-shaped county in the middle. And we have 1 critical access hospital. That's Baker City St. Alphonsus Medical Center. We have no federally qualified health centers in Baker, but we do have 3 rural health clinics. That's us, St. Alphonsus Baker Family Medicine, and then the St. Luke's Eastern Oregon Medical Associates down the street is also a designated rural health clinic, and then up and halfway is a very small but important rural health clinic that serves people there as well. So this is kind of fun. This is a Baker County traffic jam for your entertainment. I like watching the dogs because they just kind of keep them in line. And every once in a while, if you're actually driving up 86, you'll have to stop because there'll be cattle that just kind of cross the road, and you got to stop and make sure you don't run anybody over. All right. So Baker, we're not just taking care of Baker people, even though we do take care of Baker County people. We take care of people that aren't even in our county. In Grant County, to the southeast of us, has had no primary care doctors since early 2026. They lost all 3 of their existing primary care doctors, and we have people coming to us in Baker, an hour and a half drive one way. Very pretty drive, but can be treacherous in the winter. All this way just to see the doctor. And Grant County has similar population, similar health indicators. There's a hospital. This is John Day, Oregon. But, it's been a challenge to keep it staffed. And we've been seeing those people since at least 2023. I think it's helpful to know your population, know who you're taking care of. Our population in general in Baker is older, more geriatric. We do have some kids, we have some juveniles, and some young adults, but, unfortunately, young adults are more moving out of the area than moving back into the area. Some are coming back. Then we have, a pretty big chunk of people from 40 to 64 and 65 and older, and even old over 85 years old. We have a really high percentage of veterans, 13% in Baker County compared to the state average of 7.9 in Oregon. Keep in mind that the closest VA hospital is in Boise, 2 hours that way, plus time zone change. So it really takes 3 hours. You got to plan ahead to get there. And then Walla Walla up north, about 2 hours away. So we serve as primary care, community care physicians and APPs for our veteran population. And so does the Eastern Oregon Medical Association docs down the street at St. Luke's. There's a lot of extra behind the scenes paperwork, as y'all know, to manage that specialty care Every single person that needs a service outside of the primary care office needs a request for services, additional paperwork, approval. It's a lot of work, but we do it because we need to do it. Transportation services is also a challenge. And by definition, a lot of our veterans are older, sicker, more health challenges. And we have a relatively high population of people with disability, about 22%, compared to the state average, about 14%. So we also hear from our people who access our services that they have long waits for appointment times. The cost of services is a barrier for many. The insurance problems and complications. I mean, just in the last year and a half, we've had tons of people with managed Medicare and Humana who were not on service with St. Alphonsus, and then they all went to St. Luke's, and then St. Luke's terminated their contract, and they are all coming back to St. Alphonsus. And, you know, you can imagine how challenging that is for us as well. But I thought this was really fascinating that just in 2025, just from the St. Alphonsus side, not looking at St. Luke's because we don't have those population numbers, just our patients from St. Alphonsus, nearly 8,000 patient counters. In 2025, we drove from Walla, Union, and Baker counties to Ontario, Nampa, Meridian, and Boise for specialty care. That average round trip is about 266 miles per patient. Keep in mind, that's an all-day trip, you know. That's a day off work. That's a day off work for the person who drives you. The average age of that person is 63 years old. So on any given day, we have about 21 patients on the road at any time from our rural communities to St. Alphonsus facilities for specialty care. Diabetes is rising in Baker and in Oregon. That's not a surprise if you look at our lifestyle disease across the map. But interestingly, when I compared Florence, South Carolina to Baker City, Oregon, our rates of diabetes were very, very similar and rising. And, you know, of course, all of the downstream effects of diabetes complications, as you well know. Top 5 poor health outcomes for Baker survey respondents. 33% said mental health. Aging health concerns, 27%, access to healthcare, 27%, dental and oral health, almost 25%. Still, COVID-19 was at top of mind when they surveyed in 2023 at 18%. And then community mental health, 60%. This is a huge problem in Baker. We do have a community mental health called New Directions that, you know, does the best they can, but it's still under-sourced, under-resourced, and we don't have nearly enough to serve our community for the needs that we have. Access to healthcare, aging health concerns, cancer, death, health and obesity, weighted fairly high, about 12% for poor health outcomes in Baker among Baker respondents to that survey. This is a very striking statistic that is quite frankly frightening. Our suicide mortality, the people who die of a completed suicide in Baker, is twice that of the rest of Oregon. And in 2024, we had 11 completed suicides in Baker County. One of them was a school counselor in one of our rural counties. And it's tragic. And I think there's probably not a person in Baker who's not been touched by suicide in one way or the other. They know someone, they know they go to church with somebody, they have taken care of someone who's lost someone. And I mean, just a little side note, I ended up in South Carolina because my best friend's husband died by suicide and left her a widow with 5 children. And I was like, well, I could work anywhere, I could be somewhere. So I went to South Carolina for 20 years and went back to medical school and residency and then came back. So you know, it's something I think we're talking about more, we're doing better, but primary care alone cannot manage the suicide crisis. We do not have the resources to do it. Just found out earlier this week that people on suicide hold, a psychiatric hold for concern of suicidal ideation and intent in our ER. We just lost approval Monday of this week to get those people to a separate respite area outside of the ER. And so all of a sudden our ER is going to be over flooded with these people who previously had a safe space to be while they were getting stabilized. And because of an interpretation of a 1960 law that says that we cannot put mentally unstable, suicidal people in the same place as substance use treatment facility, which is where we were housing these people, that we don't have a place to put them. So that's going to hit us very hard, very, very soon. All right. Baker County also has, as you might imagine, higher rates of substance use and smoking. I was amazed when I came here, and our rates of smoking in Baker County are higher, 24% in some places, than they were in tobacco country, where I lived in Florence, South Carolina, literally tobacco country, which was about 16, 17%. So that's pretty amazing. Now it is getting better. It's coming down. You can see it's slowly trending down. We're about 18% now, maybe still higher than a lot of Oregon. That doesn't count vaping. We're not really looking at that. We don't have information on how many are vaping. Maybe that'll come with the next survey. I know that a lot of people will try to transition from cigarette smoking to vaping to try to get towards quitting. I don't see very many of them quitting. I don't know if y'all do. Alcohol-related mortality also very high in Baker. Accidents, other alcohol-related disorders, consequences of severe alcohol use disorder. And again, not a lot of treatment. So I want to share with you one of my favorite patients. This is Mr. Elsie. He is a 70-year-old male. He gave me permission to share these slides because he wants anyone to know if they can be helped. He is so thankful for the help he got. He's a 70-year-old white male veteran. He has a history of awful peripheral vascular disease. He's been smoking for 50 plus years. He's a Vietnam veteran, tail end of the Vietnam War, I believe. Hypertension, heart failure with preserved ejection fraction, previous MI, COPD, history of substance use disorder, a little bit of meth in there. He had a prior testicular cancer. He's had hepatitis B and hepatitis C with cirrhosis related to that. And he'd been doctoring this wound on his foot himself for a few weeks. And it wasn't getting better. And then he decided he better come in. So this was somewhere around, mid-December or so. And I was like, ooh, that doesn't look good. So I think it was actually our PA who saw him first, got him to wound care. I saw him for follow-up. Wound care was doing their thing, trying to get it better, wasn't getting better. He came to me again for follow-up a few weeks later, near the end of January 2025. He had a cold, pulseless foot that looked like this. And the picture doesn't really do it justice, but you can see that frankly necrotic second toe. It didn't blanch. I mean, all of those toes were cold. I couldn't find a pulse anywhere. I couldn't even barely feel a popliteal pulse on this guy. And I'm like, dude, I'm really worried about this. I need to get you over to the ER where they can get you to where there's a vascular surgeon, because I think you're gonna lose the foot and if not the leg. And he was in shock, but he agreed with me. We got him over to the ER. I spoke with the ER physician. He was life-flighted almost immediately, probably within 30, 40 minutes. He was in the air. He got to surgery, to Sarmac, had a 6-hour complicated revascularization. And believe it or not, I will show you pictures of what that foot looks like. Save not just that toe, not just the toes, not just the foot, the whole leg. $66,000 life flight bill, which he said the VA paid all of. That's actually, I've been told, a typical life flight bill from Baker to Boise Sarmac, $66,000. And that's what it costs. Follow-up praise. Patient just told me last month that he and his wife quit smoking after 50 years. But this was immediately after surgery. He had a successful revascularization. He now had pulses. Some scary looking eschar, but I was told, I think Dr. Madsen, just give it time. It's going to be okay. Watch it. He was still doing wound care. A year later, that's his foot. It's pink, it's warm, it has pulse. There's not a wound on it. And that is the power of, being able to get, someone urgent care when they need it. So we're very thankful for that. Poverty rates in Oregon, in Baker, are higher than the rest of Oregon. About 42% of our people have some level of poverty. And, about 16% food insecurity in Baker compared to the rest of Oregon, which is a little bit lower. We are very rural. This is a frontier county, as you can see. We are very much in a food desert. We have one grocery store right now, and then kind of a sort of grocery outlet, which, you know, has been stepping up and doing better, but really, really limited food resources, even for those who can buy their own food. If you don't have money to buy your own food, we have some active food banks and those kinds of things, but that's still subject to, you know, what is donated and what is given. Another one of my patients, looks like she was just seeing Zach a few minutes ago. I'll have to check and see how that's going. So remember, first week or so of biochem, first year med school, nothing basic about basic sciences. I went back to med school when I was 37. I was a PA for about 14 years. And I thought I would sail through, and then biochem hit, and I was like, oh my God. So yeah, that challenged me a lot. Remember lysosomal storage disorders? You thought you'd never see this, right? Well, out here in Baker, I got a patient with a lysosomal storage disorder and every known complication. There's not an organ in her body that is not affected by complications of that disease. She's 40 now. She lives here. She lives in rural Baker County. This is where she grew up. This is where she wants to be. But anytime she needs specialty care, which is often, whether it's OHSU in Portland, where her geneticist is, who's seen her since she was a young teenager, to where her cardiology and oncology and you know, nephrology specialists and endocrinology specialists are, you know, more towards Boise. It's at least, you know, a 4 to 6 hour round trip. You know, if you're going out to Portland, I mean, it takes me 6 hours to get there, but I stopped a couple times. And, you know, if you have to go to, you know, the Tri-Cities and Washington or, you know, wherever there's specialty care, it's going to be further than we are here. But unfortunately, her experience over the last 20 years with this disease has been delays in diagnosis, delays in treatment, substantial caregiver time off work. Her mother is her caregiver, but her mother has to work. There's financial strain, and loss of vision and progression of serious disease. First case when she was about 30, and her mother wrote this up for me, which I really appreciate. She was very forward that she wanted to share this information. She had acute vision loss of her dominant eye. She had a history of a renal transplant several years earlier when I think she was in her early 20s due to the lysosomal storage disorder. Local ophthalmologist saw her and said, oh, I can't treat this. I don't really know what's wrong with you, but I'm going to send you to Tertiary Eye Center 6 hours away. She went probably as soon as they could possibly get her in to that eye care specialist who still couldn't find the problem, the optic nerve problem, and she was blind in that right eye, sent home the same day, 12-hour round trip. A couple years later, she's 32. She has a carotid aneurysm. This was found, a small carotid artery aneurysm on CT in a local emergency department. I think she'd had some dizziness or something for that, to get that CT. And she was referred to a vascular surgeon 5 hours away. This math is just kind of to show you how far this woman has to traipse around to get to specialty care. So we're here in Baker City, right here in the center, right? To get to Boise, Kuna, Nampa, this is about 2 hours that way. To get to Walla Walla, about 2 hours that way. To get to Portland, all the way over where Oregon Health Sciences University is, where a lot of high specialty care is about 300 miles. So that's, you know, it's a long trip. But she was sent to the vascular surgeon 5 hours away for consultation and imaging. They asked her to come back later that same week for more testing. So 2 long trips, 2 days off work for her parent. And then between ages 33 and 38, so now she's got the lysosomal storage disorder. She has renal transplant. She is, of course, on renal transplant suppression drugs. She has a weird, not quite type 1, not quite type 2, somewhere in between type 1.5 diabetes. And we don't have endocrinology here in Baker. We don't even have endocrinology telehealth services, which would be great. That'd be really nice if we could. So she's referred out of town 4 hours round trip every other month to see a specialist to get the best treatment for her diabetes. And so every time she goes, her mom has to take a half day off work for transportation. And then when she's 38, She has chronic thrombocytopenia. She traveled 14 hours round trip to a hematologist, diagnosed with ITP, and not treated at that time. Now she's 40. Somewhere between 38 and 40, she lost sight in her left eye, so she's now fully blind, and even more dependent on her caregiver. She does have a speaking glucometer, which is pretty cool because she can, she's still pretty savvy and she can poke her finger and it'll tell her what her glucose is, so she knows how much insulin to give herself. But the problem is she can't see. Her eyes don't work at all anymore. So she needs a caregiver to help administer something that she could do for herself. And the tragedy of losing the remaining sight in the left eye was that she traveled 14 hours to a cornea specialist and then a retina referral that was requested from Boise. You can imagine how difficult it is to travel that far to a place that you don't know. A 3.5-hour drive. They were 20 minutes late, probably got lost somewhere. And the clinic refused to see her in that special case. So she is now fully blind. Recently, she was diagnosed with breast cancer. She's been back and forth, multiple trips to Boise, Caldwell, and Ampho, Ontario for surgical consults, oncology visits. I think all of you know this woman. She's all of our patient. She required in-plate injections just to get her platelets up enough to be able to tolerate the mastectomy. Thankfully, she had a good result with that and healed beautifully. This was often in winter conditions. They'd have to leave at 4 or 5 in the morning to get to the specialty office for the treatment or for the surgery. Ultimately, she declined any further treatment for that breast cancer, what was probably neoadjuvant treatment, because of the cost and the time and the travel. And I think a lot of, quality of life, she just doesn't want to have to be under more treatment for something that's uncertain with already a brief prognosis for her life. And we meet people where they are, we do the best we can for them. So the reality that we know is that cancer rates and deaths are higher in rural counties. And why is it? Because we're further away. It's harder to get to that treatment. Now, we are blessed in Baker County that we have the Bootsma Infusion Center and people can get a lot of their cancer treatment here in town, which is great. But we still, we still have people presenting late. It's really fascinating. You could actually look at this. I'm afraid to click on this link, but if you all wanted to look at this link, you can actually figure out, this is an NIH, I think, tool that you can figure out what your cancer rates are in your county, in your state where you live. And it's really fascinating. So here in Baker County, right here, 158 to 173 deaths per 100,000. Which is fairly high. The highest, interestingly, is down here in the southern coastal counties. And then strangely in Lynn County, close to where I grew up, a little bit in Lincoln County on the coast. I think this is probably environmental. My grandparents, when they first moved here from North Carolina in the 50s, they lived in this area on that southern coast. And that was all paper processing. So, and then Lynn County is paper processing, not anymore, but it was. I'm not sure what's going on in Lincoln County, except that now it's just tourism and a beautiful place with too much crowded beaches. But here, we've had mining, we've had agriculture, we see a lot of cancer and higher cancer deaths in Baker than some of the more well-off parts of the state. And, this is basically the metro area. These are just our very low populated counties here. Just not enough people to probably have much of a population count at all. But why do we live here? So, yeah, I can tell you all the things that are negative or, stressful or challenging about Baker, but it's a really beautiful place to live. When I came to interview 4 years ago, I first interviewed in Boise, and I was like, Boise's fine, And then the next morning, drove down. I had no idea. I grew up in Oregon, but I grew up in Western Oregon. I'd never been to Eastern Oregon. I'd never seen this side of the state at all, which is kind of sad, but that's common for a lot of Oregonians. And you drive down 84. Anybody who's made that drive knows you drive down, you're driving. Pretty soon you pick up the Snake River that starts to follow you. And then you're driving into through the mountains and through this beautiful, beautiful just terrain. And then you drive into Baker, and in Baker, it's this beautiful bowl of mountains all around you. So we have almost a 360 view of the Wallowas and the Blue Mountains all around us, and a really unique climate and culture. Yes, we really do have cowboys and rodeos. And these are pictures. I think Zach shared some of these pictures with me. Thank you, Zach. I think this one was from Pam, one of our ortho medical assistants. This is literally the view from my office window. So whenever I'm feeling sad about my life, I just look out my window and that's my view from my office window, in case you want to be jealous. And then little love notes. Patients give us Valentines. This little kid said, "Thank you for keeping us healthy, Doctor, whatever your name is." Love that. We're doing a lot of community outreach. I realize I'm getting close to time here. Know us before you need us. Tony and Shelley have been doing a lot to get the word out because we've had a lot of challenges in Baker, you know, since we closed the birthing center in 23 when I first came here. We had to close our ICU. We've now just reopened the IMCU, which is helpful to keep our people closer for more care. And then briefly, who is St. Alphonsus Family Medicine Group? Myself, I'm the physician. Jackie Adams is a nurse practitioner. Zach Allen, a PA, and Jennifer Hoffman, nurse practitioner. None of us has one job. We all do lots of things. Jackie has recently gone to be the outreach nurse practitioner to our assisted living centers in Baker when there was a change in staffing there. The previous nurse practitioner who was there isn't there anymore. And that's 130 patients that she goes 2 days a week to, you know, try to keep out of the hospital as best we can. And we're really thankful for that because they're all pretty complicated. Jen Hoffman is also our APP director for primary care. Zach also does child abuse investigations. And then I'm the rural health director, VPMA of Baker City, and the hospice director. So we're all busy doing lots of things, but it's because we love to do what we do. Our volumes in the Baker Clinic have gone way, way up this last year or two even. Some of that makes sense because it was Zach and Jackie holding down the fort here, and then I came in late 2023, and then we added Jen Hoffman. So we've nearly doubled our visits since then. And if you see our clinic visits by age group, we have a lot of much older adults. We have relatively few children. Historically, that's been because the St. Luke's group down the street delivered the babies, and we did not deliver the babies, so they kept the kids. Our payer mix is kind of what you would expect for a rural health clinic, but it's very, very Medicare heavy. So Medicare and Medicare Advantage makes up, about 42% of our pie. And then Medicaid and managed Medicaid, which is EOCCO in Oregon, is about 26%. That's a little bit low for community health clinic, but it's just because our shift is so much towards the Medicare population. We do have a smattering of private insurance, commercial, of course, our own patients. We do some work comp. And our top 10 diagnosis codes, hypertension. I'm sure you're all shocked since we're doing our hypertension initiative, but this is actually from the end of 2020 through February 2026. The second one, general adult medical examination, that's our veterans. They have to come in once a year to be recertified to continue to receive community care benefits. So there's a lot of those, tons of diabetes complications, anxiety, chronic pain, and that's what we do. Our critical access hospital, lots of people who keep it going, but actually a very small, there's only about 5 of us, and so that's why we're all on a bunch of committees. But even so, we got a Performance Leadership Award in 2025, putting us among the top 25% of rural hospitals, which is pretty cool. And I'm going to skip ahead because I know we're running short on time. I just want to tell you some added services that have come to Baker, which have been incredibly helpful. Dr. James Gardner has come from Nampa twice a month since 2024 to reopen our endoscopy services, much improving our ability to provide endoscopy, EGDs, and colonoscopies, both screening and diagnostic for our patient population who just can't travel. Surgical ophthalmology, Dr. Hansen comes. Of course, we have telehealth oncology at Bootsma Infusion Center, strong leadership locally, cardiology twice a month, St. Al's cardiologists come. We have an amazing wound care and infusion team. And we are working really hard on general surgery coming back, which we really, really need. So this is my request. The things that we really need, I mean, the goal is earlier care, fewer crises, and providing care where people live. Rural people are tied to where they live. You know, they don't want to travel. Many of them can't travel. They don't want to move. They don't want to be told they should move to where the services are. They, you know, many of them, they've been here for generations. This is, you know, they may have no wealth other than land, but that land is their wealth. That's what they do and who they are. But we have lots of needs. We need an RN case manager for Baker City Rural Health Clinic. We need stable behavioral health services. I would love to see more enhanced integrated services. My first job out of residency, we had an integrated behavioral health clinician in the clinic. I could go down the hallway and say, hey, I need some help with this person who's in crisis. That enabled me to go and be more productive with the next person and make sure that that person was plugged into services. We don't have that, but we really need that. We need more oral health. There's only one clinic in town that does dental for Medicaid, and it's a long, long wait. Dr. Capper's going to retire sometime in 2027. We need another orthopedic surgeon to expand that. We need stable rehab services. We're still operating on a lot of locums for PTOT. And that's very expensive and long wait lists. And I would love a transportation bus to get our people from Baker to the specialty services. And you know, it'd be really amazing to have a mobile rural health clinic to get to the outlying areas, even if we did that once a month, something like that, and pick a spot. We are down 4.5 primary care full-time equivalents in Baker. That is a reality. That is a calculation. We really need 4.5 more of us. So my final thought with you is that it's distance, not diagnosis, that drives the poor outcomes in rural communities. If we can fill that gap, we can save lives, limbs, vision, and dignity. And sustaining our investment in local access is not a rural accommodation. This is not something you do for a write-off or because, you know, we're, you know, the little sister of the bigger facility. It is because it's a cost-effective quality strategy to prevent transfers, disability, and system fragmentation. And one last beautiful picture. And I would love to take questions and comments.
Thank you, Dr. Lanning. Any questions? I've got a couple. I was thinking about, can you hear me okay?
Pretty well, thanks.
Okay. I was thinking about that patient that you were talking about with this lysosomal storage disorder and, you know, coming down for a visit and then having to come back 2 days later for more tests. It feels like we could do better, at least in our own system, for coordinating care and trying to get everything done while the patient is down here. Yeah. What are some of the barriers that you've seen? What, from your perspective, you're up there living it, what could we do differently?
Oh man, the transportation bus would be huge. I'm going to bring this question out to my people in the room. I've got Dr. Beach, I've got Zach Allen, I've got Jackie Adams. What do you guys see as what could we do better to minimize that back and forth for these people who need that high level specialty care?
I know that St. Luke's in Boise has some rooms or has availability, even in Fruitland when they go to their cancer treatments. And I could be wrong, but this is just what I've been told by my patients. They have housing that's available for use for either cheap or free or subsidized or whatever. That would make all the difference in the world. People can usually get there. They have family, they have friends, they have a car they can borrow, they can blah, blah, blah. But there's no place to stay. And nobody out here has money for $200 a night. Plus, I'm sure you could find a sketchball hotel in Boise if you really wanted to, but nobody needs a no-tell motel on State Street. So yeah.
I like that idea. I think just housing, temporary housing for people who, you know, I mean, our birth situation, I mean, we're having people having to spend the last 2 weeks of their pregnancy, you know, in Boise or close to Boise. Maybe they've got family there, maybe they're lucky enough, but, you know, we have people who rent an Airbnb, and most probably couldn't afford to do that. And that also includes them taking time away from work and their families. So it is a difficult situation all around. But I think some housing, temporary housing would be huge. That would be great.
I also think a nurse navigator, so like somebody that could come and say, okay, you've got to see pulmonology and you've got to see cardiology, or, you know, you've got to see, you know, 3 different people. Let's get this all organized and have somebody who can advocate for them or something like that.
I would love to see that as well. That could be maybe the RN case in. That would be amazing. One question I'd love to ask you, because I know that we're about out of time, but for you all who are specialty that we are sending people to, are there things that we could do on our side to make it easier or make it more clear, you know, what we're asking or what it is that we need from you?
Do you have any specialists in the room at the moment? I think we can bring that back though and ask the specialties that.
Yeah.
Oh, well, oh, sorry. My menopause brain.
I'm with you.
I'm going to give her the mic, just a sec.
No, I think that a couple of things that are always helpful is even just like a doc-to-doc handoff, just because it gives us a little bit of perspective of the resources available to those patients. You know, that's a little bit specific to OB. And as you were stating, when those patients come and we only meet them for 1 visit before their delivery, and they're staying in Boise with family, I think it's just nice to be able to have a connection in the Baker City community as we're looking to, you know, transfer postpartum care back or things like that. So I think that can always be helpful, and just knowing that we're a resource and kind of improving the communication between the clinic groups and stuff, I think is a goal for the organization.
Yeah, and you know, we're not doing the prenatal care or the postpartum care for the most part here in the Baker Clinic, but they certainly are at St. Luke's. Maybe that's something that we need to, you know, I act as liaison, so maybe I need to reach out to them and talk about that a little bit. Awesome. Well, I'm really thankful for the time and for being able to speak with you all from Baker. And thank you for everybody in the room who was able to come and support us. And hope everybody has a good day. It's beautiful out here today. I don't know what it's like out there.
Thank you, Dr. Lanning.
Thank you.
So I think we have another short break here. We will pick things up again at 1:45.
I'm thankful.
Hi, everyone. There's so much food. We have a lot of to-go boxes, so please take as much as you can. We don't want it to go to waste, and hopefully you can have a second dinner tonight.
All right, guys, we're in the home stretch. Thanks to everybody for hanging in here today. We're in our final two talks, and I am looking forward to this talk about perimenopause and menopause because it is a very hot topic, literally in the Nelson household. Glad to learn some more things today. Dr. Karissa Keenan, who is our next speaker, attended medical school at the University of Washington and completed her OBGYN residency at the University of Utah. She practices full spectrum OBGYN care, including gynecological problems, such as abnormal bleeding or painful menstrual cycles, menopausal transition and hormone therapy, adolescent care, and infertility. She caters to both low and high risk pregnancies and enjoys creating personalized care plans with her patients. She performs a wide range of surgical procedures, including minimally invasive hysterectomy, prolapse surgeries, cesarean deliveries, and many other low-risk procedures. She is the WWAMI site director for the OBGYN rotation at St. Alphonsus and loves being involved in medical education. Currently, she is the Women's Health Service Line Medical Director and Facility Medical Director for Boise and Nampa, for both the Boise and Nampa OBGYN clinics. In her free time, I don't know how you have free time, but in her free time, she enjoys spending time with a husband and 3 children. She enjoys reading, golfing, and is an avid football fan. Dr. Keenan.
Thank you. Can everybody hear me okay? All right, this is my best illustration of what perimenopause and menopause feels like for patients. And it's really been kind of referred to as truly chaos. It is a change in a woman's life that is really undescribable, but we're going to do the best that we can in this moment. Quick outline is just going through, and this is really presented as though we're speaking to a patient. A lot of times we're getting these questions, whether we're a primary care provider or a women's health provider. Patients want to know your opinion, regardless of the subspecialty that you may practice in. But additionally, you become a very popular person at book clubs and family gatherings when people are trying to discern what's true or not true on social media and those types of things. So the kind of big transition, people, I think when you really want to get into the nuts and bolts of it is what exactly is happening to create such a change in your lifestyle. The definition of perimenopause says the period of a woman's life shortly before the occurrence of menopause, which is a terrible definition. It's very, very practical, but doesn't really describe what's happening. Again, the more accurate thing is it's a zone of chaos. A lot of things are changing. There's decreased hormone production. Patients start to ovulate less frequently, which creates irregular menstrual cycles. And all of this, which we'll get to a little bit later in the presentation, affects every single body system we have, our brain, our bone, our heart health, etc. This is the other lovely piece. It can happen anywhere from 6 months to 10 years before you actually transition through menopause. As a patient, how do I know if I'm in perimenopause? People will start to notice a lot of these symptoms. Again, irregular menstrual cycles, mood changes. You start to notice some hot flashes, night sweats, more joint pain, more irritation. They call it brain fog, memory problems, a word on the tip of your tongue that you just can't get out. And then some weight changes and kind of where that weight distribution occurs. The diagnosis of perimenopause is very much related to symptoms. People want a lab value. We want to understand exactly how close we are to menopause, but it turns out it's not quite that easy from a diagnostic standpoint. We recommend baseline labs for things like thyroid testing, checking a prolactin, things like that to rule out other causes that could create some of these symptoms, but not labs to necessarily tell you where you're at in that journey. This is just a quick picture of the menstrual cycle. And I just like to point out to people that your estrogen changes, the progesterone changes. And so if you look at trying to, again, use an estrogen or progesterone lab value to tell somebody they're in perimenopause, that lab is going to be significantly different based on where they're at in their menstrual cycle. If your menstrual cycles are now irregular and unpredictable, we can't best guess on what day of your cycle we're checking a lab because we don't know if your period's going to happen every 30 days, every 45, you had 2 cycles in 1 month. And so it's really, really tricky to follow those lab values. what can patients do about this? I think first and foremost, having open conversations with providers, because it is such an appreciated transition. And a lot of times people hesitate to say, I'm having brain fog, feel extra moody lately. My husband or my partner is driving me crazy these days, and it wasn't that way 6 months ago. I just don't feel like I'm performing as well at my job because I'm having some memory challenges. Those are vulnerable conversations to have with people and to share, especially when we look at this perimenopause and menopause phase. And it's oftentimes women who are in the heat of parenting, oftentimes sort of peeking into their career, where it's really important that they're able to balance all of those things. And then we just throw all of this chaos onto that and expect them to continue to perform and function in that manner. So there's, kind of just like the prototypical things, but some of this has been pretty well studied, that really increasing protein intake, a heart healthy diet, decreasing caffeine and alcohol can help with the hot flashes. Interestingly, weighted vests and strength training has been really shown to decrease the muscle mass loss that we see in perimenopause and menopause, as well as the risk of osteoporosis. And then yoga, and that's probably more just a mental calming of that chaos. There's not a ton of data, but there's a little bit of support around these phytoestrogen-rich foods. So you'll see people add like flaxseed, soy, or fiber into their smoothies and things like that. And when you look at the kind of the structure of the chemicals, there is a good crossover with these and estrogen receptors. So there is probably a benefit. You would have to likely consume a massive amount of flaxseed to overcome some of the estrogen deficits. But if it helps, I tell people even 5% of your symptoms, sometimes that's the difference of survival or not. Herbal options, as we know, oftentimes aren't quite as well studied in medical literature. But if you talk to herbalists and kind of functional medicine providers, these are some of the base ones that people do report some benefit. But it seems to be pretty individualized. And we always want to be a little bit mindful, because those certainly can have medication interactions with other medications you may be on. So I tell people, before you go to try those things, make sure you're talking to us about that to ensure that we're having a safe option. And then we get into medication options, and there's a lot of different medications out there. There's hormone-based therapy, which typically is deemed to be the best option because we know that in perimenopause, we're getting those decreases in hormone production. So naturally, repleting some of that hormone is helpful. There's various other selective estrogen receptor modulators, SSRIs. So typically we think of those a little bit more often as antidepressants or anti-anxiety medications, but low doses of those can help quite a bit with some of the hot flashes, night sweats, and mood changes. Gabapentin, clonidine, and then interestingly enough, cognitive behavioral therapy has been shown to decrease some of those symptoms. And I promise we'll get into more of the details of treatment. It just correlates very much with menopause. So again, the interesting part of this is the definition, if you just look it up in the dictionary, is that you're just done having menses. And most of us would like to celebrate that, except you're still having all of these symptoms. And so at this point, we really know the definition of it is your ovary is no longer releasing eggs. It's the end of fertility, and you're going to continue to see decreased hormone production based on the changes from the brain talking to the ovary in that season. This is all the same. It's very much the same symptoms. The difference is that people will stop having menstrual cycles. If you've had a hysterectomy before this season, an endometrial ablation, things like that, then that's where we go to the labs and say, we can check these to see if people have like officially crossed over from that perimenopause to menopause state. And so that's checking an FSH and an estradiol, and those numbers, the FSH is greater than 40, and then the estrogen will be less than 20. It's the same stuff that we talk about doing in terms of treatment, and looking a little bit more at HRT versus OCPs. So OCPs being combined hormonal contraception. You can still use those in menopause, but we find that doing the separated hormone replacement therapy is a little bit more effective and has lower rates of DVTs and things like that. And then this is a new medication that's come out that's really focused a little bit more on hot flashes and vaginal dryness. The data shows that there's, a benefit, but there are a fair number of side effects and just not a ton of data out there to support that as a first-line therapy yet. This is probably the million-dollar question, and what's all over Instagram and TikTok and all of the things is, what's the deal with the hormones? What hormones should I have? What dose? How do I get them? And how much benefit are they going to provide me? So in general, we have estrogen and progesterone, and testosterone as our primary HRT medications. And these are sort of the things that we're really looking to treat. So when we look at FDA approval for these, it's vasomotor symptoms, prevention of osteoporosis, so that's not a primary indication, replacement for patients who may have had primary ovarian failure, and then vulvovaginal atrophy, so genitourinary syndrome of menopause, which creates vaginal dryness, painful intercourse, those types of things. When we look at it, a lot of people have different stylistic takes on how you should do hormone replacement therapy and really assessing patients' severity of symptoms, the impact on their quality of life, and then again, people who may have any contraindications. What's interesting is when we started to really look at hormone replacement therapy in a more detailed and thoughtful fashion over the last decade, they started to do more assessment of receptors in the brain. And it turns out there's estrogen receptors in the brain. Turns out that's why, as our estrogen decreases, we have more mental lag, don't feel like we're as quick on our toes, feel like we have a little bit, more of a challenge with memory. And that's truly, it's biologically affected. That kind of leads into the same with sleep disturbances, same with muscles and bones. We've really found that this component of our kind of hormone balance impacts, truly every system of our body in a pretty profound way. And then the same with vaginal tissue has a lot of estrogen receptors. So as that decreases, you get the vaginal dryness. And with that, you can get microscopic little tears or opportunities for bacteria to get into the urinary tract infection and can cause increased risk of recurrent UTIs. So we know that estrogen is very protective against those things. When we look at starting HRT, the ideal time is to really do it within the first 10 years when they've officially crossed over into menopause, and ideally patients less than the age of 60. That doesn't mean that these people are not candidates to do it. It just means you want to have an assessment that they do have a slight increased risk of stroke and blood clots. And that we've really only found that with oral estrogen. If patients are able to tolerate the patch, then that risk goes down to baseline. But just things that you want to make sure you're looking at before you start prescribing. And then there's always a question of, how does this impact my risk of cancer? So, estrogen and progesterone combined has a slight increased risk of breast cancer after 4 years of use. And that is only like a 1 to 2% increase for patients that don't have any other risk factors for breast cancer. Estrogen only, it's very slight, and that's at the 7-year mark. And then patients who have a family history of breast cancer, but no genetic mutations, don't actually have an increased risk that's any different than those two that are listed. So even if you had a family member who had breast cancer, that doesn't eliminate you from an HRT qualification. Just a little bit of the kind of details, and I think these are a lot of questions that come out. Estrogen is really only an option for patients who don't have a uterus. If you have your uterus, we know that estrogen can stimulate the lining of your uterus and it becomes thickened and a little bit chaotic in there. So that puts people at increased risk of precancer or cancer cells. Progesterone is our friend and it keeps the lining of that uterus thin, which is why we can give patients estrogen who have a uterus, but they have to take progesterone with that. There's 3 primary ways to get estrogen. One's an oral medication formulation. We have transdermal patches and then vaginal rings. The preferred method is the transdermal estrogen because it bypasses one of the cycles through the liver, and so it decreases the risk of VTE, so DVTs or stroke. and tends to have just a little bit more of a consistent release of that hormone versus the kind of daily peaks that you'll get. Progesterone, there's the micronized progesterone, which we also tend to use as our first line for HRT. So that's something like Prometrium. Synthetic progestins are also options. That'd be something like a norethindrone. But we do know synthetic progesterones tend to have a little bit more side effects from that perspective. And then there's combined patches that have become more readily available over the last 3 to 5 years. And then most of the time with the combined, again, we try to do a patch with an oral progesterone from that perspective. One question we get a lot, and there's a couple of studies that are underway right now, is if I have a patient with a Mirena IUD or a levonorgestrel IUD, do I have to give them a different form of progesterone if I start them on an estrogen patch? The answer is currently yes, just because we don't know with 100% certainty that that is protective enough. The theory is that it likely is. We use progesterone IUDs for prevention of the development of endometrial cancer for even patients who have abnormal cells already, but it just hasn't been looked at enough to feel safe doing that without talking that risk through with your patient. Testosterone is the up and coming hot topic, and you'll probably get a lot of questions about this. There's the cream, gel injections, and then they have oral formulations and pellets. Even though there's no FDA approval, they've removed being a female off of the black box warning, which is helpful. And there likely will be some formulations coming out soon, but it's 10% of the male dose. So if you're ordering this, it's typically to a compounding pharmacy where you want to have that decreased dose. And we tend to prefer the cream and the gel. The injections and pellets have been shown to have more side effects. So patients are having abnormal liver findings, increased cholesterol panels, and then we're seeing some increased risk of like colon cancers and cancers in men that are a little bit more unusual for women. So that's getting studied a little. But just we generally don't recommend those formulations because you get this big spike in the testosterone and then tends to overwhelm the system a bit. And then currently testosterone, the only sort of diagnosis is a hypoactive sexual disorder. So testosterone's really been geared towards the sexual function and changes in perimenopause and menopause. However, we know that there's likely benefits, especially with muscle mass and bone health with testosterone as well. There's vaginal symptoms, which oftentimes, again, people don't always have a lot of, they don't feel like they have a safe space to talk about these things, which feel very vulnerable. But it's important, I think, as providers to just ask patients if they're having any sexual dysfunction, pain with intercourse, or vaginal dryness, because there's a lot of things that we can do. Vaginal estrogen does not have a high rate of systemic absorption. So even patients who have a history of breast cancer are candidates for vaginal estrogen, and it can be pretty transformative for their lifestyle. So I always tell people, certainly ask patients about it because they may not be forthcoming when they're visiting with you about their symptoms. And so there's, a fair number of different alternative therapies. I would say most of the time it's pretty rare to get into that window of needing them because these three do treat over 95% of patient symptoms that are vaginal specific. These are the contraindications. So patients who have abnormal uterine bleeding, and again, the hard part, right, is that is perimenopause. But with that, we just want to make sure that we're not missing a precancer or cancer diagnosis. So oftentimes recommending an endometrial biopsy for patients who may have risk factors for that, checking a TSH, those types of things, just to make sure that we've ruled everything else out. And we feel like this falls into the perimenopause section. And then patients who have a history of GBT or PE, generally you want to make sure that they've had a full workup so that you understand what that clotting disorder was. Hypertension, if you're on a blood pressure medication and it's stable and you're doing well, you can be on HRT, but if it's uncontrolled, you're on multiple medications and still tend to always have elevated blood pressures, then that would be a contraindication. Obviously, liver failure, liver disease, any type of estrogen sensitive cancer. So patients who've had a history of breast cancer are not candidates. And then a history of VTE, they always put that that's relative. So if it was provoked from a surgery or things like that, then you can talk to a patient about the risk benefit and see if they still would like to proceed. But obviously, if they've had any active VTE in the last 5 years, that's a contraindication. Or if they got a VTE while taking combined hormonal contraception, then that would be a contraindication. This is kind of the stuff that's really come into light. And I think, again, the research into this area has really expanded over the last 10 years. And the accessibility of hormone replacement therapy and the discussions of testosterone supplementation for women has really changed the game. And so when they've been looking at all of the benefits of HRT, this is what we're seeing. And again, we know that there's estrogen receptors in the brain. We know that historically we've talked about estrogen being a very like pro-heart hormone. And so it has cardiovascular protection. We know that as women, really age 30 and on, we start to lose a fair bit of our bone density. And so it makes sense from a bone strength and structure standpoint that it's helpful. And you can kind of see the list here, but the one that's really become a little bit more notable is really the muscle mass and joint health, and just that sort of like daily pain, feeling like you're not as strong as you once were, challenges to keep doing what you're doing in the gym or going for runs and those types of things. So the muscle mass and joint health is one that I don't think we screened or asked patients a lot about in the past, but have really started leaning into that in our questionnaire too, to see how their daily life is affected. Not just, I think the hot topic is mood, sleep, hot flashes, night sweats, but there's so many other things that go into it that we should talk to patients about. This is, I think, one thing, and just from a patient perspective is, I think people just don't want to necessarily always have a conversation about these things and feel a little bit hesitant because when does it really start? What age did my mom go through menopause? Is it just because I'm stressed? Is it just because, my job is very stressful? Those types of things. And so anytime I have a chance to talk to patients, or if I know I'm getting a referral from somebody to talk to a patient about this, I always ask them to start kind of listing out symptoms that they just feel are different from the last couple of years. And it can be any symptom for any health system, to just really talk about that. And then to let them know, like, hey, we're going to talk about uncomfortable things. We're going to talk about sexual health. We're going to talk about intimacy, libido, those types of things. Because at least in my opinion, if you can't talk to your primary care doctor or your women's health provider about that, I don't know who else you're going to have a sounding board to discuss with. The other component that's really helpful for us as an OBGYN who's seeing these patients is to understand how different are their menstrual cycles. Have they become irregular? Have they noticed changes in their volume of bleeding, lighter, heavier, more pain? And then knowing that, we kind of get a big picture. And then oftentimes this leads to a series of follow-up appointments to discuss what symptoms are most bothersome. Do you want to start hormone replacement therapy? We should reassess how your symptoms are doing in 8 weeks because it's not uncommon to need an adjustment in a dose. If you don't feel like it helped immediately, that doesn't mean it's failed. This is oftentimes like many other medications. We need to titrate it. We need to adjust it. We need to talk about, are you having any side effects? So I tell people that this is a bit of a journey, and you should kind of prepare to see your OBGYN or your primary care provider who may feel comfortable doing HRT, to have some frequent follow-ups to make sure we get you into a good, safe spot with whatever medication it is you decide to do. Or if it's just lifestyle changes, but you just want to be able to touch base about the severity of symptoms if that changes. But we should have some increased accessibility for that. And then I always just kind of give this to people for just general references of these are the screening guidelines. ACOG has a lot of information out. The Menopause Society is sort of the tried and true for OBGYNs, and they provide a lot of wisdom and information in terms of formulations of HRT. They're developing currently a kind of protocol to start people on testosterone therapy, as that's just recently become a little bit more popular and available for women. And then these are just a couple of other nice resources for patients if they need a patient handout or things like that. And then these are quite a few different books that are pretty powerful and have a lot of great information. Dr. Casperson is a spokesperson who went to the FDA and pushed really hard to get the black box warning label adjusted on testosterone. And a lot of these providers are leading the way on clinical studies and work to try to get, like female dosing that would be FDA approved and more easily accessible. We find that patients in rural settings that don't have access to compounding pharmacies and such, it's very challenging to get testosterone to those patients. And so just, a couple considerations from that point. And then interestingly enough, there's a documentary called The M Factor that they put together that interviewed a lot of the leaders in this space and interviewed a lot of patients to get their stories and talk about kind of workplace changes and how employers and family and friends can be helpful and supportive in this season of life. And then there's a lot of great online content if you're looking for recommendations for diet changes or foods that may help with symptoms to exercise routines and things like that. Dr. Casperson and Dr. Haver have really great websites that you can kind of type in your question and then they do a great job of answering that. I know that's a lot of information and I made it a little bit brief just because I feel like there's probably a lot of specific questions potentially about this. Yeah.
What is the role of hormone replacement therapy, including testosterone, in the woman in her 60s with the diagnosis of osteoporosis?
Yeah, it's interesting. I think that, at least from my perspective, and in our clinic, we would recommend hormone replacement therapy for those patients. They always say like that's probably not, not the only primary diagnosis that we should use it for. The patient is totally asymptomatic and they don't feel like they have any other bothersome symptoms. Per the guidelines and requirement, HRT isn't a first-line treatment for osteoporosis. The reality is that we know there's significant impact on not only the bone health, but also the muscle mass. And so from that perspective, we would sit down and talk to them, and I would certainly be supportive of starting somebody on it. Yeah. Yeah, and I tell people, I'm like, it's just all like full disclosure, in my opinion, of let's talk about it. These are the numbers we know. The increased VTE risk is about 3 to 3.5%. So it's not, massive, but it's there. It's real. But if a patient has no family history, no personal history, and they feel like all of these symptoms that I have is worth that increased risk, then it's not a hard no to prescribe it. It's just informed decision making. Yeah, it's interesting. I don't do it very often just because most patients respond best to estrogen. Some patients who've had a history of endometrial cancer or breast cancer, even though we know those aren't contraindications to vaginal cream, tend to feel a little bit nervous, or they just really would prefer to avoid any hormone-based treatment. And that's usually when we'll use that.
Do you have a preference on OCPs for perimenopausal women that are looking for therapy?
Yeah, a couple of them that we like to start with. Sprintec is one, low-estrin. Mostly things that have the norethindrone, progesterone component tend to do a little bit better. And I should include it. We have a really great chart in our clinic that, there's like 11 different types of progesterone. And in those, they have different, what they call progestin activities. And so you want one that's kind of just right in the middle to start with. But those are the two that we typically use as a jumping off point.
Dr. Keenan, I've got an online question for you, and then we'll keep going around the room. I have a couple here. You touched on this just a little bit, but the use of vaginal estrogen in the presence of ER positive and ER negative breast cancers. So the use of that
Yep, you can use it.
Okay, and then follow up, same question on testosterone in post-breast cancer patients experiencing sexual hypofunction.
Yeah, it's interesting. They've looked at this and say that patients are still candidates. The actual conversion of testosterone to any type of estrogen kind of subset. We see that, we'll talk about it with patients with increased peripheral adiposity and things where a lot of those sex steroids can get converted into estrogens, but we don't see that for the transdermal testosterone. So it would definitely be something to talk about.
And I know we have some more online questions, but we'll go back and forth here because we've got about 15 minutes for questions. So
I have a patient that is estrogen receptor negative breast cancer like 10 years ago. And she was really struggling with her hormonal symptoms. And so I just went over the risks with her and thoroughly documented in my note, but I offered her hormone replacement. Did I do the wrong thing?
No, I think that's perfect. I would have done the same thing. And I will say we get a lot of referrals for that exact reason, which, patients say it's still a risk, history of breast cancer, but as long as it was ER negative, that patient's still a candidate. Typically, I don't know if there's any oncologists in the room, but would love, for them to be like 5 years out from their diagnosis, which I think makes sense. But even then, I've had a few patients who at 3 years are like, I can't, keep living my life this way, and I'd rather start the HRT. And I do the same thing. I just document a lot and have frequent touch bases with them just to make sure they still feel comfortable with that risk.
Dr. Keenan, one thing I've been a little confused about is what is the most current data as far as dementia risk decrease or neutral with HRT, same thing with heart disease?
Yeah, it's a little bit extrapolated from the sense that we know for women who've gone through menopause but are younger than 65, there was lower rates of dementia and cardiac disease for those patients who retained their ovaries. And so we know that there's probably some level of estrogen that helps with that. The preliminary information and sort of what has been published over the last 18 months is that there likely is a pretty significant improvement in dementia and cardiac disease. The hard part is there's so many confounding factors to be able to isolate that clearly. And it's been especially with all the GLP-1s and stuff coming out with some similar data. I think it's going to be a little bit hard to delineate that perfectly. But when I talk to patients about the benefit, I talk about bone, brain, and heart health being improved.
Thank you so much for your presentation. I have a really quick question, and then after that, the quick, easy question is, if you do use HRT, if you use Premarin, how do you decide on dosing, where to start?
Yeah, I typically, so when we look at the kind of easy answer is that the lowest dose that's effective, which doesn't sound great, but I do a lot of permetrium, so I always start patients on 100 milligrams to start with, and then we know that if they're continuing to have symptoms, then you can go up to 200. So that's, and then there's like the conversions of those estrogen and progesterone doses if you're changing modalities. But there was a long time that they felt everybody needed to be on 200 for adequate endometrial protection, and that's not been proven to be the case. We know much more than 200 people start to have pretty significant side effects from the progesterone.
Thank you. And then this question, I'm going to be honest, is kind of a pushback question on the comment in the slide that said breast cancer's contraindication. I read a recent review, and I honestly can't remember how this study was organized, but it was either in the New England Journal or in JAMA, a really comprehensive review that they concluded that even women who had early stage breast cancer, node negative, that had been completely removed, even with an ER positive tumor, that it would be okay to use hormone replacement therapy if it was indicated. I was moved by that conclusion.
Yeah, no, and I know exactly what you're talking about. I think the tricky part from a provider standpoint is is sort of those like national guidelines, organizational guidelines. So that article came out, the Menopause Society and ACOG and all of those still have not adjusted it. And the oncology departments in general haven't embraced it. So while I think that study is good, I think people feel like they'd be going out on a ledge at this time to prescribe it, if that makes sense.
I have another online question and then we'll head back to the room. This question is, when uterus is intact, can you start one at a time? I'm not quite sure what they mean. Well, starting one and gauging what symptoms are improving.
The recommendation would be to start both, just because even a couple months on unprotected estrogen can increase your risk of endometrial hyperplasia or cancer. Typically, at least my approach and most people in my clinic is we start with estrogen and progesterone replacement, see how people are doing so that you can try to figure out sort of their symptom improvement. And then if patients are continuing to have, persistent sexual symptoms or brain fog, then that's when we kind of add the testosterone. I, in general, don't start all three because I think it's very difficult to know how to titrate which one and if patients are getting improvement, from one or the other. So progesterone is less titrated. We typically have just, 1 or 2 doses that we use from that perspective. Estrogen has a lot more dosing, especially in the patch form. So we oftentimes will kind of adjust and make sure we've optimized those 2 medications first and then look at testosterone. When they've looked at it, 0.5 to 1 milligram from an oral perspective. Mm-hmm.
Talking about testosterone, in men, we have to prove that their their testosterone is low. And there are female levels for the one patient that I tried to get gel for because she said it was important.
Yeah.
And it was low. So, but are we going to be required by the insurance company? I mean, you're doing it for a completely different reason.
Yeah.
But are you going to be required at some point to do testosterone levels like we do in men?
Yeah, it's interesting. I would anticipate that there's probably going to be some hoops to jump through, just knowing pharmaceutical companies and insurance, if I had to guess. And typically what we recommend is getting a base testosterone level and then a SHBG before you start it, as well as just a lipid and CMP panel, just so that you can, check on that 3 months after initiation. I haven't seen anything come out since the black box warning was removed, but we still have to compound that 10% dose. So I think we kind of slide by it right now, but it wouldn't be surprising to me from an insurance standpoint.
And the last question, one of the things that Robert Kennedy Jr. did was that he eliminated we've been forced to take our patients off at 65.
Mm-hmm.
That has been a force.
Mm-hmm.
And yet you have people who say, I can't think. And so some of us have had to do lots of prior authorizations.
Yeah.
So what do you think about what has happened there? I mean, he says quality of life versus quantity.
Mm-hmm. No, and I think that that was really kind of like that anecdotal from the Women's Health Initiative study where it just, that cutoff was just sort of arbitrarily created. And so again, I think because that's been so ingrained in the medical community and people haven't really stepped out on that ledge again, I just have really in-depth conversations and then sign the prior auths and document it. But I don't force my patients to get off their HRT at 65. I've seen it more. I don't know if it's just late bloomers that I still have signed a few in the last month, but I'm hoping it continues to get better.
Would you mind just walking us through dosing for compounded testosterone?
Yeah, so it's just at least in our like Epic system, but essentially there's just like your testosterone cream, so the standard male cream. And then below that, you just have to put like in your comments, the 10% dosing in there. There's no like other way from a compounding standpoint to do it, if that makes sense. Like you don't have to do the math on it because it doesn't exist in our ordering systems. Yeah, it's a little bit like frustrating.
Yeah, and just quantity and where they applying it and how frequently and all that.
Yeah. So patients, I kind of tell them, I mean, you can kind of pick your location, but typically we recommend not any area that, is necessarily touching your kids or things like that. So most people are doing it on their legs or upper arm. And, whether you do it a day or night, I tell people just to create a regimen that works for you. And then to kind of avoid, don't wipe it, don't touch it until it feels like it's dried, just to not have any exogenous exposure to people who may not be low on the testosterone. And then typically people apply it daily.
I don't see any more hands. Thank you. And
Yeah, thank
for
you
the time
guys.
for questions.
I guess just like one plug, our clinic, there's been a few, I don't know, rumors or anything, but I think patients have a hard time navigating this and end up in functional medicine clinics, which I think have a role, but then get very confused or have a lot of compounded medications and challenges with their current prescriptions through our practices. And so our clinic, anybody who does GYN in our clinic does HRT management. We follow the NAMS or the Menopause Society guidelines and all practice fairly similarly. So I just always encourage people, if you have patients who have a complicated situation or on sort of a whole host of hormone replacement things from an outside clinic that need kind of readjusting and management, that we do, our clinics do that, and that it is available through St. Al's. And I think sometimes that gets lost in the shuffle of all the internet marketing and social media stuff. So just wanted to tell everybody that.
All right, well, we have our last speaker for the day here. Dr. Nicholas Kuntz is a board-certified urologist who joined Idaho Urologic Institute in 2021 after serving as a urologist for 11 years in the United States Army. He's a native to the Treasure Valley, a graduate of Eagle High School. He received an undergraduate degree from Whitworth University in Spokane, followed by a medical degree from St. Louis University School of Medicine. He completed a general surgery internship at Walter Reed Army Medical Center, followed by a residency in urologic surgery and a research fellowship in endourology at Duke University Medical Center in Durham. Before returning to Idaho, Dr. Kuhn spent 5 years in practice at Landstuhl Regional Medical Center in Germany. He's well-versed in a full spectrum of urologic conditions and specializes in Da Vinci robotic surgery and other minimally invasive surgical techniques. He has special interest in the treatment of prostate and kidney malignancies, as well as BPH or enlarged prostate and complex kidney stones. Dr. Kuntz, thank you for being here today.
Thanks. All right, thanks everyone. I know this is the last talk of the day, so I'll try and keep it as brief and practical as possible. I want to give you some tidbits of information that you can use in your own day-to-day clinics. We certainly appreciate all the referrals y'all send us. I'm one of 10 urologists at IUI. Currently, we're looking for some new hires and some PAs, but hopefully we're able to get your folks in a timely manner. I have no disclosures. This kind of are my learning objectives. The main things I want you to take home from today are just some things you can implement. This is a continuing medical education talk, so you can walk away and use in your clinics if you see some basic urologic issues in the coming weeks. And then some obviously practical points of when should I refer someone for urologic evaluation. I have devised this in a Jeopardy style format, but probably that's not going to work too well with this environment. So I'm not going to put anyone on the spot. I'm just going to go through some of these, and I may open it up for questions after each topic because it's going to be a case-based. Rather than waiting for all the questions at the end, you may have some questions as we go along. So I'm going to start on men's health because that's primarily my practice, and we'll move on to some ambulatory. If we don't get to all of these, that's fine for the sake of time. But also want to get you guys out early if possible. Okay, so the first case scenario is a 55-year-old male that complains of trouble getting an erection. So some of you may reflexively say, this is not something I want to address or deal with, which is fine. We're happy to manage those, but there are some very practical things that can be done. So erectile dysfunction, as defined by the American Neurologic Association, is the inability to gain or maintain an erection satisfactory for sexual performance. So there is a subjective component to that. You're going to find men are coming in all over the spectrum. Usually, as some of you guys know, this is something that as you're walking out the door, addressing their 5 other things, they say, oh, by the way, it can be kind of painful. So, so initial evaluation, the vast majority of these will come down to idiopathic causes, some cardiovascular issues, testosterone. Has been shown to be a risk factor for cardiovascular disease, so it can be considered, and with the lipid and other cardiovascular risk assessments. And so you can do all those typical things that you would do for those things, checking, glucose, A1C, lipids. Testosterone actually is indicated in the most recent AUA guidelines. It's something that you can screen for. Someone mentioned that testosterone replacement does require certain values below a certain range, usually around 300. Now that's for insurance to pay for it. Oftentimes the injections are really cheap and inexpensive, and there can be some symptomatic improvement. And we know, basic things like Viagra do work better when testosterone is higher. So some cursory cardiovascular risk assessment, some basic labs, including the testosterone, typically covers most of it. So the most common organic causes are going to be listed here. Certainly diabetes, obesity, hypertension, the common metabolic syndrome. Endocrine dysfunction is going to be the minority, but certainly you can pick up on some men that have really low testosterone that have been subclinical for many years, but can certainly improve. And this may be one of the presenting signs and symptoms. So certainly don't forget lifestyle modifications. Usually by the time people make it to your clinic, you've already hounded that many times. So most of the first line treatment options, besides some of that cursory initial evaluation, these do not require $1 million workup. Optimizing, hey, I just started a medication and all of a sudden they can't get an erection. If you can tweak those, there are some antihypertensives that can be commonly associated with that. So do as much as you can on the front end, but also most of the medications circumvent the underlying issue and have a very high success rate. So the classic PDI, PD5 inhibitors, the Viagra, Cialis, and Levitras, these are all off patent. They're very inexpensive.
No, we are trying it down lower right now, and she's.
Yeah, go ahead.
No, I would double dose the H2 blocker. I mean, you're not going to get you actually go up.
Try to mute somebody.
But
yeah,
I would double dose that so that you got that overriding.
The online, $7 free, what's the real deal on that?
Right. So most of those are getting, so any pharmaceutical, when it comes off patent, they want to find a way to repurpose the same thing and charge more for it. So all of the things, the hims and the hers and the combination, things like that, are going to be combinations of the sildenafil and the vardenafils in a combined dose. Now, those people like it because you don't have to walk into a clinic and talk to someone, but you're going to pay a lot more, and they do charge you for an online physician or provider visit. So it's the same old drugs that have been used for a while. They're just repurposed and rebranded, essentially. Yeah, and they're not wrong. They're not good. It's not good or bad. They do, it's the same active component. Yeah. Did you have another? But that's a really good question, because we come in with people, and there's probably 10 of them now on the market. Yeah.
Testosterone levels, when do you draw them? And does it make a difference if it's just total or free?
Yeah, I probably should have put in a testosterone case scenario, because it's taken off in our clinic in the last 5 years, and it can be really confusing, and we do a lot of it, and a lot of the men's health clinics do a lot of it. So pretty much any new case or a new patient that's coming in with this as a primary complaint or an AND complaint, it would be reasonable to do. And a total testosterone from a screening standpoint, I think, is completely sufficient. You get a baseline assessment of how severe is it, and how likely are they to gain symptomatic improvement if you can increase their levels. And so if we have like a 40-year-old that has a level of 300, but they have a ton of symptoms, or maybe it's 350 or 400, I'm not opposed to increasing their levels for 6 months or a year and reevaluating their symptoms, because a lot of men should be, may feel a heck of a lot better when their levels are higher within reason. So there is a lot of monitoring that goes into that, but a baseline screening testosterone will put you in the right hemisphere. And if you want to manage it, you can. If you don't, then send it on and we can do that for you.
Timing of what time of the day? Or
Early AM. So before 10, 8 o'clock, or as soon as the lab opens should be fine. Yeah. Okay, so the classic PDE5 inhibitors, Viagra, Levitra, Cialis. So a lot of treatment failure, early treatment failure actually comes down to, improper use. So these will bind to fatty things in your food and will get excreted. So if you want maximum absorption, ideally on an empty stomach, 30 to 60 minutes before anticipated sexual activity, these do not work on their own. Okay, I tell folks, this is a take the foot off the brake pedal. It's not a gas pedal medication. So you got to provide the gas pedal. This just helps prolong and use that. It's binding a specific enzyme and blocking it. That enzyme, starts the turn off mechanism for the erection. You definitely don't want to take it at the same time as someone on nitrates. If someone's on some nitrates for chest pain, it's not that you can't use it. They just need to know they shouldn't take it at the same time. And the most common side effect is going to be headaches. So we talked about the medication failure. It's not going to work the same every time. There's obviously other psychosocial factors that go into this event. And so if they take it once and say it didn't work, I would say, well, you can dose escalate. You can start at a lower dose, increase to the maximum. If you're on the maximum strength and you've tried one or two of these, that's where I would consider moving on to something more invasive. And clearly that's where we come into play. So a couple of the take home points, they have to, do stimulation. You want to make sure they've tried different doses at different times on different days and not taken with food. So these are some of the really interesting up and coming things that are still not definitively useful, or as far as we can tell, based on what's available in head-to-head trials. Low intensity shockwave lithotripsy, these are offered at some of the men's clinics. The current stance from the AUA is we don't know yet if this is useful. Clearly there is some anecdotal evidence, and we see patients that have had it and it's useful probably for younger men with more mild disease. And the purpose of that is you go and you have one treatment and then you don't need to take medical management or medical therapy moving forward. So we see why it's attractive. There are some ongoing trials that are looking at it, and we may have some better evidence. We hired a infertility and men's health expert or fellowship trained guy 2 years ago, Dr. Muncie, and we're trying to have this as an option, if not to be useful for clinical trials. Intracavernosal, so injections into the penile tissue of stem cell therapy and PRP that has shown evidence in joint rehabilitation and injuries in that regard. It is being used, it is being done, but officially there isn't any high level evidence that it's efficacious. Just for your own information, these are the things that, if medications fail, are available. There are really good and cheap or relatively inexpensive vacuum erection devices. Some men really like these. They're fairly cumbersome to use, but they're non-invasive. There's almost no downside to those, and they're fairly straightforward and easy to use. Muse is a formulation. It's an intraurethral suppository. They're fairly expensive, but it's the same medication that's injected is put into a little pellet and gets absorbed transurethral. Probably the most common next step up after medications fail are intracavernosal injections. And there are, different mixtures of that, L-prostadil, and there's trimix and quad mix and things that are compounded. And then those are self-injected. There is a fair amount of teaching, so that's not something you're going to want to prescribe and send someone out on their own to do that. You want to know, our PAs do a really good job teaching men how to do that, so they're not injuring themselves and they make sure they're getting the right dose. This is something that you can overdose on. Viagra, of every priapism I've ever seen in the ER is never from Viagra or oral medications. It's always, it's most likely to be from these intracavernosal injections. And then lastly, the penile prosthetics, you'd be shocked how many of these are actually done, even in this area. So there are, there's some upfront pain and suffering that goes into that, but after a few months, the patient satisfaction rates are actually quite high. So a few take-home points. Men that are consistently taking oral nitrates for angina and chest pain probably should not be on a PDE5 inhibitor. It can create a hypotensive crisis. Or similarly, high cardiac risk where the act of sexual activity would cause so much strain on the heart. But those are just a couple to be aware of. Like I said, there is some good evidence that erectile dysfunction as a presenting sign is an independent indicator of underlying cardiovascular risk. And then certainly many of the first-line oral medications can be done at the primary care level, and then referral if those are not successful. Any other questions on that? Okay, moving on with men's health. So these next two scenarios are the two that I'm most excited to talk about because I was listening to Dr. Dattani's talk, and clearly they use a lot of Da Vinci robotic surgery. So urologists, robotic surgery was invented for urologists. I mean, we're talking 30 years ago. It was a urologist that implemented it, and it was designed by the military to be able to use laparoscopic surgical interventions remotely. Interestingly, that just happened last year. A prostatectomy was performed by a urologist in Florida on a patient in Africa. So, it took 30 years, but it actually was just recently accomplished. So, that being said, urologists continue to push the envelope in terms of technological advances and robotic innovations. And we've been partners with St. L's for a while, and they recently invested in two really state-of-the-art robotic interventions for both prostate cancer and BPH. And so we'll talk about those in these next few slides. So a 62-year-old male with difficulty urinating without knowing anything else. These are the initial differential diagnoses, and your history can be targeted at determining which of these is most probable. Certainly men do develop urinary tract infections, although much less commonly than females. BPH by far and away is going to be the most common presenting symptom with someone coming with these complaints. And then there are some other things, prostate infection, those are going to be more acute. Overactive bladder in men as a underlying diagnosis almost always is secondary to BPH, but they can present with more irritative voiding symptoms as opposed to urinary obstruction. And then in the age of prostate cancer screening, we rarely see prostate cancer as a presenting sign for lower urinary tract symptoms, but occasionally bladder tumors can show up as irritative voiding symptoms in overactive bladder. So it's certainly on the list. As a refresher from med school, benign prostatic hyperplasia, or BPH, is the benign growth of the tissue around the urethra. There's two different zones of the prostate. Cancer primarily is what's called the peripheral zone. That's why it can often be palpated on rectal exam, whereas the area right around the urethra is called the transition zone. This is what it actually looks like. So this is a cystoscopic evaluation. The picture's on the right side, so that's retroflexion of the cystoscope, which is in blue, looking back down at the bladder neck, and you can see that mound of tissue that's projecting. It just doesn't create a lot of space for urine to flow. Now, over time, what that causes are the pathologic changes on the left side. So that's a bladder wall or dome on the bottom one there. That is an overuse pathology. I mean, you can look and see the smooth muscle of the bladder is being infiltrated by cartilage, basically. It doesn't stretch, it doesn't squeeze very well. And those are end-stage bladders. Those are very, very hard to treat. Not everyone that comes in with BPH is on that trajectory, but we want to treat those before they get to that stage, because even the most aggressive operative intervention often is not helpful for those. And the difficult conversation of telling a man you're never going to be able to urinate on your own without a catheter is challenging, and oftentimes it's preventable. These are the classic BPH voiding symptoms. I'm sure you've all have heard of these or seen plenty of it. So slow urinary stream, intermittent stream, stopping and starting. Waking up at night any more than 2 times per night would be pretty abnormal. And then urgency, the frequency, as soon as you gotta go immediately. There's some really good intake questionnaires where you don't have to tease some of this information out. They can do it before you see them, and you get a good idea of, is this a mild or moderate severe symptom case? Am I more likely to do behavioral modifications? Am I more likely to progress to medications or even surgical management? These may be things that you want to turf to us, and we're certainly happy to do that. But it is a good way you can get a baseline snapshot of how severe things are. Excluding common things like urinary tract infections, which do happen. Rectal exams, I know some of you may still do those, you may not. It's kind of an optional thing if you're comfortable doing it. It's certainly not harmful. And then PSA. So most Medicare guidelines will grant one screening PSA for prostate cancer. If someone comes in with BPH, you can order a PSA under that code and it will get covered. So it is a surrogate marker for prostate size and can be useful. Again, it's not common. We're finding prostate cancers in men that come in with lower urinary tract symptoms, but occasionally if someone does come in and we check a PSA, it can lead us down that diagnostic pathway. So assuming you do all that evaluation, they don't have a urinary tract infection and they meet criteria for BPH, you'd be shocked at how much information can be gleaned from avoiding diaries. I mean, in behavioral modifications, watching fluid intake. I have had, men on report on avoiding diaries, drinking a gallon of coffee a day and just outrageous amounts of diet sodas. And so simply tweaking some of those things can improve a lot of symptoms. Once you've exhausted that, the first line my go-to is an alpha blocker, something like Flomax, Uroxetrol, Rapaflo. They're all in the same class. They're quite well tolerated. They have very few side effects. I use very little 5-alpha reductase inhibitors. Some of you may be aware of the black box warning from a few years ago. It may increase the risk of high-grade cancers. That's not the reason I don't use it. I just think for most men, the side effect profile, they're not willing to give up some of the sexual side effects. The only time I use this in combination is men that really are poor surgical candidates. And then anticholinergics and the beta-3 agonists, I rarely use because, again, most of the overactive bladder symptoms are actually due to obstruction and not just overactive bladder. The other reason I don't use 5-ARIs is that they take a long time to take effect. Those are actually going to shrink the prostate by 25 to 30%, but it takes a while. And then it also skews the PSA values. And if you don't know to correct for that, so I don't use it terribly often. Alpha blockers, something that you need to be aware of. It's not harmful, but men will stop taking if you don't tell them is the retrograde ejaculation. So it will decrease the resistance at the bladder neck, which causes the path of least resistance backwards instead of forwards. The second most common is dizziness, and then nasal congestion or feeling like you have a sinus infection. So these are one of the reasons that men stop taking these medications and go a more surgical route over time. The 5-ARIs, is mostly sexual side effects, ED and libido stuff. And then the anticholinergic commonly are constipation and dry mouth. But again, in most men, I rarely, if ever, use those. So obviously the reasons to refer someone for further diagnostic testing and potentially surgical intervention are, you felt something on rectal exam, there's blood in the urine, that would take you down a different trajectory, even though BPH can cause hematuria. Certainly a high PSA, urinary retention, and urinary tract infections in men is not common, and it's a good sign that the bladder is not working well. So these are a couple newer surgical interventions. Everyone who's went to med school probably has seen a TURP at some point, and those are still done. They're still fairly common. What's improved are kind of the less invasive options. So on the smaller prostate gland size, this is effectively like a coronary artery stent for the prostate. It has a little bit different design, but the same philosophy. So you're implanting this device. It's basically 2 metal clips with a permanent suture. It acts as like a molly screw would, and if you're familiar with any home remodeling. So you're basically moving the prostate lobes out of the way, thereby opening the channel. It's attractive because it's very quick. It takes 10 to 15 minutes to do. You don't need a catheter. You're going to be back to normal within a matter of days. With anything that's less invasive, the trade-off is typically efficacy. So there is some chance you'll need another intervention at some point, and patient selection is, not everyone is a candidate for this, but it can be useful. This is the most recent treatment that we launched this year, actually. It's called aquablation. So it's effectively a TURP, but the energy source is using a water jet, and it's completely AI and robotically driven. So there's very little work done by the actual surgeon. And I'm going to play just a short video because it's kind of hard conceptually to get your mind around how it actually works, but sometimes watching something like this is useful, and it's kind of cool. So I'm going to turn this off because I don't know if it's copyrighted or anything, but I'm just going to talk over. So like I said, we just got this. It looks like it's using a water jet to destroy prostate tissue. There's two devices that are done in real time. One is transrectal ultrasound. So the whole thing is done under image guidance, not just with the ultrasound, but also the cystoscopic element where the actual water jet is used. So once we pull in the individual patient anatomy, which is shown here, we base our treatment plan targeted to the patient's anatomy. The working element is the cystoscope, which is combined with the water jet unit. So it's an 8,000 PSA water jet. It's not heated. It's just water, and then the ablated tissue then gets sucked through those channels on the other end. So this is what a typical treatment would look like. Once the transrectal probe is inserted and the working element is inserted, we take all the measurements and then we plan the treatment. So I'm basically hands off at this point once all the instruments are docked to the robotic arm. All of the planning of the treatment is done on the monitors, where we're deciding what are the specific anatomic structures that we want to avoid, the ureteral orifices, certain areas of the bladder neck, the sphincter muscle, and then preservation of ejaculation is one of the main benefits of this treatment over the classically used options. So as shown here, they're in 2 dimensions, marking the treatment plan, avoiding some of the structures. That's what's called the Viru protection zone. In the yellow, that's what preserves ejaculation. And then once all that's set, there's a foot pedal that actually executes that treatment you just planned. This is, it's much faster than that, but effectively, if that schematic is showing you what the machine is actually doing. Treatments are extremely fast. Even with huge prostates, you're talking 5 minutes or 10 minutes of timing. There's very little time involved in that. And then at the end, we do put in a resectoscope to cauterize. So that's just regular water. It's not heated. It's so they do bleed, and you got to go in and cauterize to make sure men can go home after that. So by and large, these are 30-minute outpatient procedures. It still does require a catheter, but the main benefit of this over conventional options is it does preserve ejaculatory function. Yeah. Yeah, everything that we resect at the end does get sent off, but the ablated tissue, it's basically pulverized. So there's not much to send. Let's see if I can get this back up. So yeah, I do. I think over time, as more and more trainees are not doing as many TURPs, the comfort level will go down. With really small prostates, it's hard to argue the benefit because you can do a small TURP in 20-30 minutes also. But for men that are younger and want to preserve ejaculatory function, this is about a 90% success rate with doing that, where it's about a 10% rate with a regular TURP. Yeah.
So 90% success rate.
Yeah.
What's the duration and what's the cost? Duration of success.
Yeah, so I only see what the RVUs that are generated. I don't know what it is done in a hospital, so they're going to be facility fees that go along with that. It's about on par with a TURP. I mean, in terms of our reimbursement, it's really no different. A TURP that we can do in an outpatient surgery center versus one we do here, I don't know what the cash price is actually, but these are covered by all Medicare insurances and private payers, almost all. It's quite durable, right? It hasn't been out for long, and we don't even the gold standard TURP, we don't have data beyond 10 years. But when you look in the prostate and there's a big empty cavity, the likelihood that that's going to regrow in someone's lifetime is very minimal. So it's intended to be a permanent procedure.
And then how does this compare to thermal techniques? Is
So,
it called
yeah.
Resume or?
Yeah, so Resume is Resume is more in line with the UroLift, where it's for less, smaller glands, more mild symptoms, less invasive. That can be done, in an outpatient setting awake, using, microwave ablation, basically. So we don't really know why this doesn't impact ejaculation as much. One thought is the cautery and heat thermal energy that can damage some of the ejaculatory nerves, versus just preserving specific tissue right around the vira montana and the ejaculatory ducts. But this is meant to use primarily for kind of the mid to really large prostates.
So there's a role for both technologies.
Yeah. There's certainly a role for the more minor, absolutely. But Resume and UroLift and TURPs, and HOLEPs, the laser enucleation, those all come with a fairly significant risk of retrograde ejaculation. So that's where this stands out.
You said you just got the device. Are we doing these here now?
Yep. Yeah. We're about 30 cases in. And the inter-user variability is very small because, most urology have done TURPs. This is primarily plug and play. We're using the anatomy, the visual, experiences that we've done, for biopsies and TURPs. And once you dock the robot, you plan it, there's almost, the learning curve is like 1 or 2 cases. So. Yeah, you got to be pretty still because that thing moves really, like a 100-gram prostate, it's like 5-7 minutes. So it's moving really fast. And if you're moving, you got to be still. So general anesthetic. Okay, so just some take-home points. Behavior modifications can be used for BPH symptoms. Medications are a good first line. And sometimes are required. So something like aquablation, you need to have failed the medication right now for Medicare guidelines. You have to have been on some sort of oral medication for 6 weeks, I believe. And then for complicated lower urinary tract symptoms or refractory oral medications, those are kind of the ones that we like to target it on. Okay, how are we doing for time? Okay, perfect. We'll move on to the Men's Health 500. This is our classic prostate cancer screening. This is certainly highly controversial in the last decade for anyone that's been aware of the back and forth guidelines. So 2026, they had just sent out some updated guidelines from the American Urologic Association. So I wanted to touch on those briefly and just having some understanding of what the debate is. Why do some advocate, hey, you shouldn't screen, and others still adhere to that? And then the newest treatment, again, that we launched last year around this time, that I want to talk about briefly because it's going to be another, over the next few years and decades, it'll take over a lot of the way prostate cancer is managed. So the AEA was kind enough to release this nice diagram. It's an easy flow chart, but it's obviously packed with a ton of information and probably isn't useful in your day-to-day. So I've kind of tried to break it down. They're really big on this shit, who should we screen for prostate cancer, who probably is not likely to benefit, and there should be some shared decision-making, whatever that means to you, but it's more or less a discussion. Hey, this is what we could do. Here's the risk of screening. Here's the risk of maybe not screening. But some sort of interaction. And this is something we do often. So by the time most folks get to us, they've already had a PSA or 2 for a few years. But if and when to do that, obviously, usually happens at the primary care level. And then you obviously want them in agreement with that. So probably it should not happen as you just order it on a panel that you check, routinely, because then people show up and they have no idea why they're there and what the PSA is. And that, they're finding time to do that in your schedule is another matter. So when do we start? This has gone back and forth, and it's really hard to keep track of. And it's really not set in stone. So this slide really summarizes, well, there's probably a range that's reasonable. Certainly if there's, family history or risk factors, you can do it sooner, maybe as soon as 40 or 45. And just because you start at those age, you maybe get 1 level. And if it's low, less than 1, you may not do it again for 5 or 6 years. How often to do it? It's very easy to remember to do it annually, but you don't have to. That's something you can do every 2 or even 4 years. And then you can decide essentially when you want to stop screening. You know, previously at age 70, there was probably little benefit to continuing screening, but we find high-grade lethal cancers in men in their 80s all the time. So it's something that I basically say, do this until you have other medical problems that outweigh this. The reason for that, for me, is not because the studies are clear that screening on a population level is better than not screening. The reason, because that's where the controversy is. There's two studies that are conflicting on whether or not it's helpful. The reason I screen primarily is because we don't have to go right to aggressive things anymore. It allows us to know, do you have cancer? If so, how aggressive it is. We don't have to even do a biopsy right away for PSAs. It just allows men to have more insight and information available to what's going on. If they choose not to do anything, in many cases is reasonable. Gone are the days where everyone with a PSA of 4 ended up getting their prostate removed. We rarely do that anymore. And there's not a reason to. So that's why there's such a controversy. There's been a heavy emphasis now in other biomarkers that are used besides PSA. Most of those are going to be available at the urologist level. There's probably not worth your time because there's 10 or 15 of those available, trying to sift through which one is useful or not. Imaging has taken off in the last decade, where MRI is fairly ubiquitous. It's really inexpensive and is quite good at targeting and identifying significant lesions. Staging modalities with certain type of targeted PET scans, and then focal treatment options. Those are what I'll just discuss briefly. So biomarkers, classically, everyone knows PSA is not very sensitive nor specific for prostate cancer. So tons of research dollars goes into urine tests, semen tests, blood tests, anything that increase the predictive value of PSA. We currently are using something called isometric PSA, which is most helpful if it's negative. It can really lower your chance of finding cancer into the single digits. There's really nothing that gets your predictive, positive predictive value above 50%. So that's kind of the maximum ceiling for most biomarkers. But this can be useful, and this is typically what I use to risk stratify who goes on to get imaging. I'm rarely doing a biopsy without imaging nowadays. So enhanced imaging with multi-parametric prostate MRI, like I said, historically, every one of these you already had to do a peer-to-peer. Almost always now they're approved, they're inexpensive, and it gives us really good diagnostic accuracy for clinically significant cancers, not the low-grade non-lethal forms. This is what it actually looks like. Okay, so the image on the left, you can see in two different planes. That's a T2 weighted image. That's a focal lesion in the peripheral zone on the right. On the right side of the screen, again, similarly on that same side, these are all the other variations of MRI that are used. So they're not just T2 weighted imaging that gives the prognostication, but what's called diffusion weighted imaging, which is implementing contrast and other ways to predict is this a significant lesion or not. So my typical algorithm, if the biomarker suggests there's at least a 50-50 chance of being cancer, then I move on to MRI. And if there's a lesion that's at least a 50-50 shot or higher, so a PI-RAD scoring system similar to BI-RADs for breast cancer, if you're at a PI-RAD 4 or 5, the likelihood that lesion is a clinically significant cancer is on the order of 70-80%. So it's very and that would be a reasonable reason to proceed with a biopsy that can be targeted. So you're not doing just random sampling, but you're doing more of a targeted biopsy. If cancer is diagnosed, then a staging imaging with what's called PSMA PET-CT. It's a specific isotope using gallium-68 that binds to a prostate-specific membrane antigen, which is present in about 90% of prostate cancer tumors. And it gives these really pretty images. You don't have to be a radiologist to see on that image, that big glowing spot in the prostate. That's a focal tumor in the peripheral zone of the left hemi gland. So very sensitive, very specific. Primarily, this is used to exclude occult metastatic disease, so bone lesions, lymph nodes. But for focal treatment of prostate cancer, it's also very good at identifying focal lesions. We just opened our own PSMA PET scanner, FDG PET scanner at IUI. So if you have trouble getting folks into the radiology centers at St. Al's, we have about a 1 to 2 week wait time. So it's quite useful. So focal treatment options. So these have been around for a long time. The energy source is using a focused sound wave, so it's a thermal energy. What has finally caught up to the technologies is the robotic implementation and AI utilization. So it allows us to use an energy source that's been around for a while, targeted it very specifically to a portion of the prostate, and this is where it fits in. So right now, this is being used not for the really aggressive treatment that are likely, metastatic or locally invasive, but for the low grade, intermediate grade, and select high grade tumors. It's using focused sound waves, just like a magnifying glass will focus light waves and increase a thermal energy. I had a video, but it's probably not worth showing. So this is what the actual platform looks like. So we launched this in February of last year. So there's a robotic probe that the way this energy is delivered is through a transrectal probe. It has a built-in ultrasound, so it's all done in real time. Once we set the device, the actual treatment is done on the monitors. So we can upload MRI, PET scan, and know exactly where the lesion is, fuse it with ultrasound in real time, and treat specific areas. Why do that? Is to minimize the side effects associated with conventional treatment. So some of you may have had or know someone that's had a radical prostatectomy. The impact on sexual function, urinary incontinence, erectile dysfunction can be significant. And even though we're quite good at curing certain cancers with that treatment, we often can leave men debilitated from those other aspects. So efficacy, when this has been looked at head to head with radical prostatectomy, is at least a non-inferior, so about a 90% success rate, at least to 3 to 5 year windows. We don't have longer term 10-year data, but it's quite minimal. It takes about an hour. Men will go home the same day, still requires a catheter, but they're effectively back to normal within a matter of days after treatment. No incontinence. So it's been quite a new tool to add to the arsenal. And something to be aware of. A lot of men don't want to have prostate cancer screening because they don't want their prostate removed. And this is a really excellent third option, and it's been just rewarding from my own standpoint, being able to offer something to men that no one wants to have a low grade cancer, and a lot of them don't want to survey that and monitor that. So this has been really useful. Questions on that? Yeah.
With the focal ablation,
Yeah.
do you have specimens that go to pathology? Do you know if you have clean margins?
Well, there is no margin, right? You're going to calculate a margin based on your imaging. You have the specimen from the biopsy. So you base your treatment around targeted biopsy, PET scan, MRI. And then we do factor in about a 10 millimeter margin. Yeah. And then because we often don't treat a whole hemisphere, PSA is not not a good predictor of success. So we do go in about a year afterwards and re-biopsy everyone just as a confirmation test. And so that's why that 90% success rate is probably a higher success rate than we do with radiation, because we don't biopsy anyone after radiation. But yeah, so it's a different way we have to monitor it, but the trade-off for a low-grade cancer is pretty significant.
So previously, people would go in and get like biopsies, like on a grid. Now is it all gone to targeted biopsies, or are you still doing that kind of like 18 specimens?
There's never a grid, unless you don't have a lesion. It historically has been a laterally directed 12 core biopsy where you're sampling the peripheral zone. Nowadays, if there is a targetable lesion, you're going to target that area. And then once they're numb, taking a few other random samples is usually advised. You don't have to, but there can be, the focal dominant lesion, that's maybe a Gleason 7, and then a small volume Gleason 6, which is trivial on the other side. And oftentimes we won't even treat that. Yeah. But we're not doing kind of the 18 core grids anymore.
On that image you showed where it had the very bright spot, maybe six slides ago or so. With digital is kind of going out of style.
Yeah.
But if a digital was to be done on that, is that far enough lateral that it might be missed?
Yeah, absolutely. DREs on most guidelines are an optional thing because we have way more sensitive tools that when when you do a lot of transrectal ultrasounds, there's calcification. There's things that you feel that are abnormal that are not cancer. They're just not, they're not sensitive nor specific. So there is a role for it. So if someone comes in with a PSA of 100, I'm not going to do an MRI. Okay, take a feel. Yeah, that's not good. And we just go and do a biopsy. But I use a lot of imaging because it shows me a lot of, when it's negative, it'll show me a lot of subclinical BPH. So, and I can show men, I can say, this is what your prostate looks like. Your bladder looks horrible. I don't believe you that you say you have no urinary problems. I mean, and then you start testing them and then it's like, yeah, their bladders suck and they, maybe prevent a worse outcome down the road.
You're using the focal ultrasound ablation only on low-grade lesions. So
yeah, so I mean, it's right now primarily used low and intermediate, but also select high-grade lesions.
Okay,
yeah.
so you are trying to do it on some high-grade, because if you have a low-grade, I mean, the observation and weight thing is still frequently.
Yeah, if they're very low risk or low, oftentimes I'll still, hey, this is, and we can't see it. So a lot of Gleason 6, they don't show up on MRI or PET. And yeah, we can continue to do active surveillance.
Well, I'm saying like a Gleason 4 or something like that.
Oh, the low, they stopped doing anything less than 6.
Yeah, okay, great.
So there is no Gleason 4s anymore. They did, yeah. And actually there's some controversy right now in the AUA of whether or not to even call 6 cancerous anymore because of the malignant metastatic. Yeah. There's also in situ for prostate, so it gets confusing. Whoops. Okay, we doing okay for time still? Okay. We're going to move on to a few, what happened? Yeah. Dr. Keenan gave a great talk. She actually delivered my daughter about 3 years ago. I was going to say hi to her. You can go to any of those and it'll hyperlink. Perfect. Okay, so these are going to be more probably common to your guys' practices. This is pretty standard 78-year-old male with 2 days of gross hematuria. Not painful, really no other symptoms. You don't think he has a urinary tract infection. Pretty much any male of this age coming in with gross hematuria is cancer of the urinary tract until we prove it otherwise. So you already know this is someone that's going to need to be referred. How can I best tee that up so we don't delay diagnostic testing? There is a difference between gross and microscopic hematuria. It's noteworthy. It translates into difference in risk. And microscopic hematuria does require microscopy. So 3 or less red blood cells per high power field. If you only are using dipstick, it technically, we can't categorize someone with a dipstick only. So we do see a lot of that DOT physicals and whatnot, where they come in with a urine dip. And then when we do microscopy, it ends up being negative and they're upset. They're like, well, why did they send me here? So that is a criteria. A lot of folks are on anticoagulations now. That really should not be an independent. You can't absolve gross hematuria just because they're on a blood thinner. Bunch of risk factors. Most of these are pretty well known and understood. The main take-home points from this slide are folks that you don't need to automatically send for microscopic hematuria. So young folks with no risk factors, 3 or 4 red blood cells, never smoked. There is an age difference for men and women. So men less than 40, whereas women less than 60. We just see less bladder cancer and renal pathology in women for whatever reason. So these are the ones that you can reassure, maybe just recheck it, 3 or 6 months later. And then there are obviously risk factors with microscopic hematuria that do go on to need further diagnostic testing. Most of these you've learned in medical school. Certainly, smoking is the main environmental risk factor. Some other weird chemical exposures, and then pelvic radiation, whether or not they've had prostate cancer before, or colorectal radiation. Those are going to be the main things that are risk factors nowadays. If we were to do 100 cystoscopies on 100 folks with gross hematuria, only 20% of those do we actually find something on. So the vast majority of these don't have urologic cancers. Those are going to be urinary tract infections, BPH. Medical renal disease is one of those that you learn about, and it can be hard to miss, but it does happen. And usually if they're having gross hematuria or microscopic from renal disease, it's something that can be advanced and and need intervention, and then certainly renal trauma. So this is the type of workup that can be done at the primary care level, excluding infection, checking a renal function panel. Very rarely is anyone going to exsanguinate, so you don't really need to do an H&H, but if they've been having, gross hematuria, passing clot for days and days, you can get profoundly anemic from that. And then imaging. So CT urogram is important. So this, we see a lot of folks that come in with a non-contrast CT, and it can be good at how you have a kidney stone, but it can be very difficult to distinguish cystic from solid renal masses, and it doesn't clear the renal pelvis and ureters. So then we have to make the decision, do we do another CT scan or just, if it's completely normal, it can be useful, but you don't know that before you're ordering it. And then, like I said, gross hematuria almost always needs to be referred. Any gross hematuria, and certainly any smoking history, and then those other risk factors that we talked about. This is what a CT urogram looks like if you're not familiar. So there's a non-contrast phase. You can pick up things like kidney stones. There's the contrast enhanced phase where you'll pick up renal masses, enhancing renal masses, and then huge bladder tumors will enhance, as shown on the top right. And then there's the excretory phase where you're looking for polyps in the renal pelvis or ureters, which are not common, but we do see. So this is a big filling defect on the excretory phase, and then on cystoscopic evaluation, that's what a bladder tumor looks like. Any questions on that? Pretty straightforward.
We'll just take a couple of questions because we're at time, so.
Perfect. Yeah.
Nobody online can hear.
In men, they frequently only treat them a week to 10 days for lower tract
Infections?
infection, which I find to be probably not good since I'm infectious disease and most of it's prostatitis.
Yeah.
And that requires a significantly longer time. How do you make that decision or try to encourage other doctors to get?
Yeah, I agree. So we get men with recurrent infections, and they don't have recurrent infections. They were just undertreated.
Right.
So always longer, 14 days minimum.
Sometimes 28, yeah.
Yeah, I mean, yeah. I don't usually go that long unless it's recurrent or they're febrile, maybe possible abscesses admitted, things like that, then certainly. But usually in those cases, they need an operation at some point. But yeah, that's one of the presenting signs of men with horrible BPH and obstructive uropathy is they come in with a UTI, and then you start looking at it, and they're retaining, 400, 500 cc's.
And we'll take our last question.
I have a question, but it's not on ambulatory.
That's fine, anything,
From
yeah.
an earlier topic. So, and I kind of need a teleprompter because I'm going to say this wrong. But if erectile, this is on ED.
Okay.
Question. If erectile function is to propagate and produce offspring, and if we propagate when we are young, and if the prevalence of what is called ED is very high with older age, why is it regarded as dysfunction rather than as a normal part of aging? In other words, why is the word dysfunction used?
Yeah, I mean, that goes back to the definition, which is inherently subjective. And so there's going to be plenty of folks that, man, I can't get erection, doesn't bother me, doesn't impact any relationship. It's completely satisfactory for me not to be able to get an erection. But you're asking about nomenclature. I don't have a good answer for it. Yeah. Yeah. Yeah, it's a good question. Yeah. Yeah, that's true. Yeah, I don't have a good answer for you. I can tell you we treat a ton of ED in men in their 90s even. You'd be shocked. Yeah. Anything else? Appreciate, yeah.
I do have a question. Active surveillance, is that based mainly on the Gleason score or what?
Yeah. So low or very low risk, Gleason score makes a huge role in that. We're doing a lot of genetics-based assays now where the histologic risk from pathologic specimen are then either confirmed or sometimes upstaged on genetic analysis. So that's one thing I didn't add just for simplicity's sake, but almost every pathologic histologic specimen, the Gleason grading system also gets a genetics assay where we're looking at specific gene mutations that we know. I mean, prostate cancer is very heterogeneous. So you have some Gleason 6s that will become metastatic early, and the Gleason 7 in particular, some of those are nasty and some of them are really indolent. So these genetic assays, we can apply different treatments to different risk populations, but primarily it's a pathology.
Well, thank you so much.